had made a mention of monogamy. I would like to add to read a quote in this regard. Human being appears to be the only species amongst living beings who can allow and accomplish sexual act around the year and throughout one's lifetime. He can also engage in unnatural sexual act and sexual promiscuity. Man has to pay a penalty for his unnatural sexual act and sexual promiscuity. AIDS seems to be the one such. Hence, it behaves the human to honor and preserve the sanctity of nature's laws and also to realize his obligation to society through proper and time-tested good social behavior in his private life. You all know AIDS, HIV started with gay sex and slowly bisexual people and heterosexual promiscuous people and spread all over the world. So I don't take much of your time. Now, let's start today's morning session. Now I call upon from Chennai to deliver her deliberation. Months help along HIV management.
So good morning, everyone. And thank you for being here, especially after a busy and Saturday night culturals and to start these days proceedings. So women's health along HIV management. We all know that women constitute around 50% of people in fact living with HIV and AIDS, and 44% of women and people with HIV in India are women. We know what is called as the feminization of the epidemic. And we need to know that what is important is that, and this is interesting data that shows that even among women, the women are socially and culturally more prone to get these kind of infections. If you look at this data, you will see that women in low-income countries and lower to middle-income countries had a higher prevalence of HIV, HPV, and HCV and syphilis when compared to global infection prevalence rates. So, as we keep saying again and again, what is sauce for the gander is not sauce for the goose. Women have a greater immune activation. Women have a higher burden of non-AIDS comorbidities. They may be compounded and augmented by menopausal transition, potentially occurring prematurely. And they have a greater risk of social, behavioral, and structural factor that places them at a disadvantage for treatment and access to care. So, like all other women, women with HIV have three considerations that change towards their life, through their lifespan, from concerns regarding sexual and reproductive health, efficacy of ARVs, and safety of ARVs in pregnancy, which is a constantly revolving conundrum, menopause, which causes so many other complications in these group of women and other women as well, and polypharmacy for comorbidity, as we see our women aging and becoming a more older cohort than they were initially. So I think one important thing that we have to remember with our group of women when we address them is to look at their fertility desires. Because gone are the days when women did not want to become pregnant, or when they told specifically by their care providers not to become pregnant because of the risk of HIV or the risk of different types of ARV exposure during pregnancy. But now women who are younger in age group have proper knowledge of the prevention of mother-to-child transmission and who are virally suppressed and all desire to extend their family. If they feel they have not completed their family size. And very, very importantly, we have to look at the demotivators. Many women felt that widespread availability of contraception was actually a deterrent to becoming pregnant or attempting to become pregnant. And many women, when they had one child, felt that pregnancy was a burden to their health and finance. And most importantly, what we have to understand and underline, and so many years after we have started treating people with HIV, women were actually demotivated and very upset, so much upset that they had to change their caregivers because of the negative attitude of healthcare workers towards their pregnancy. Some women even said nurses had shouted at them and their care providers were angry because they had become pregnant. So the most important cause of reason why women actually wanted to become pregnant was because they felt they had not achieved their desired family size. And in context of safer regimens, knowledge of PNPCT, they would like to expand their family, or if they were in a new relationship. We see that in the clinic also. We have women who are married or who have lost a child coming back and who probably have undergone tubectomy, looking at the success of if you look at in context of the success of the tubectomy program in India. So we have women who come with desire to become pregnant. So we should remember this when we address and decide on the treatment options for these women. So these are the regimens approved for treatment in HIV-infected women, men, pregnant women, not pregnant women. And we know all the gray areas around DTG in relation to pregnancy and uterine tube defects have been removed. And these are the DHH's recommended ART for initiation. Essentially, all regimens recommend TAF or TDF with instars like dolutegravir or bictegravir, or when a protease inhibitor regimen is implicated from boosted darunavir. So we all know that there is a huge number of drugs now available, from our long-acting injectables to so many other drugs available for treatment of HIV-infected people, name and treatment experience, the regimen for initiation, regimen for maintenance. But of all these huge basket of drugs, those approved in pregnancy are only the following few. This is mainly because of lack of data or inefficiency in pregnancy. So we see bictegravir becoming part of most pregnancy, most regimen now, and we will slowly see women on bictegravir becoming pregnant. And this is a study that was presented in Troy last month, which looked at 27 mother-infant pairs. So they did PK sampling in the second and third trimesters of pregnancy and postpartum. And of these 27 mother-infected infant pairs, mothers, only one mother was viremic with a viral load of more than 200 copies, and she had some adherence issues. And all other women were virally suppressed through the pregnancy. No infant acquired HIV. But when you look at the pharmacokinetic data, the area under the graph was 49% and 56% lower during the second and third trimester. These two lines are the ones in the second and third trimester. And this is in the postpartum peak. So this was roughly around 30 to 35% lower during the second and third trimesters. But no infant acquired HIV in this cohort and no women were viremic. But still we will have to look at how the data evolves around bictegravir in pregnancy. So another important and interesting development is the use of long-acting injectables. So are these we have some data from when they were used in PrEP, but when you look at women with HIV becoming pregnant, the effect of long-acting injectables. So this was a modeling prediction. The advantage of this is that women do not have to be subjected to PK study, 10 PK studies. So this was modeled for monthly injections, total of 6 injections starting in the second trimester. So when they modeled, they found that the trough concentration after the first injection was 29% and 23% lower in pregnancy compared to outside of pregnancy. So this is the blue lines are the ones in pregnant women and as compared to the data PK available from the non-pregnant women. So this study shows that in a monthly dosing, there probably could be a lower exposure of rilpivirine long-acting drugs in this group of pregnant women. And this is an interesting other data from the Weave group, which published from the women who became pregnant in course of their studies. So these are multiple, this is a multiple drug exposure cohort because some received monthly, some received 2 weeks, somewhere in the washout period. But they reported a total of around 25 pregnancies. And of this, all women were I think you've got an overview of what is coming. So they reported a total of 25 pregnancies, of which 10 were live births, 8 women underwent elective abortions, 6 were like 24% were spontaneous abortions in this group. That they attributed to the increasing and very rigorous pregnancy testing in these groups, which could have identified very early pregnancies. 1 ectopic pregnancy, which was operated, and no stillbirths in this group. of these 10 live births, all women who became pregnant were discontinued from the long-acting injectables, and only one woman in this 10 continued on the CAB-LA. So there was 80% of infants were all full-term healthy infants. No infants acquired HIV. There was one preterm low birth weight infant with congenital ptosis, which this was resolving at follow-up. Only one woman on this group continued rilpivirine LV, and she had low levels of viremia. So data keeps coming up, and we will have to keep looking at how this, because as it comes into wider use, and I think we will see more women getting pregnant and deciding pregnancy, and we will need to know what the options are for these women. Just to reiterate that in spite of ART, women with HIV have a higher incidence of adverse perinatal outcomes, which can be low birth weight, very low gestational age, small for gestational age, and multiple other. ART reduces the risk definitely of adverse perinatal outcomes, and even in women on ART, as compared to women without HIV, they still had, though they had a better outcome compared to women with not on ART, they definitely had a little disadvantage when compared to women who are HIV negative, as you will see in this graph. The first one on the top is the one comparing the women with HIV with on ART without ART, and the second one is women with ART as compared to HIV negative women. And what is on in a continuing conversation, because guidelines are not static, we have newer evidence, newer drugs coming up. What is important is this revision of the guidelines updated on Jan 31st, which was discussed extensively in CROI in a separate session as well, where infant feeding guidelines have been changed for women in the United States. We know we encourage women in India to breastfeed with appropriate counseling regarding the risk of transmission. So what this guideline has now said that individuals, though formula feeding is preferred or replacement feeding is preferred in this group, and even though viral suppression can only reduce the transmission to less than 1%, women who are suppressed on ART wanting to breastfeed their children should be encouraged and supported in their choice. So we have newer drugs coming in, and we have two main molecules that are being increasingly used in maintenance or continuation regimen or doravirine, and two drug regimens of lamivudine and dolutegravir. And we have this is an interim study results from a pilot study which was presented in the Glasgow HIV and Drug Therapy Conference. So this is a study with 100 HIV positive ART experienced women in South Africa who were rolled on to doravirine and tenofovir. And this group was 92% were virally suppressed, and they were 97% of all AEs that occurred, which were related to doravirine, were only minor and grade 1. They did not see any serious adverse events related to the drug. And there were significant favorable responses with the lipids. And very importantly, median weight gain at 24 weeks of 22 kg. This is just a pilot study, and we will have to look at further data on this. This is what I found a very interesting study on the real. This is a pooled analysis, a review from a real-world experience with dolutegravir and lamivudine in women with HIV, which particularly looked at three studies which had sex stratified results. So one was a prospective study, and two were like cross-sectional studies. So what was very interesting in this study is that of the studies, two studies reported safety outcomes in relation to sex, and they found that women seem to discontinue the regimen more often due to adverse reactions, and mainly women seem to report a high incidence of muscle aches, which does not seem to be reported in any other cohort. But anyway, it was still biologically very efficacious in that group of women who were studied in these three studies. And what is very, very important and has to be reiterated and underlined and said again and again is that of the 8,000 people who had been enrolled after the studies, only 254 were women, and that is only 3%. So which is hardly any. It just underscores the fact that how little women are, how sparsely they are represented in clinical trials. And when we keep talking about, the advanced study opened the Pandora's box on weight gain. And so this what they did kind to alleviate, they tried switching the women, the participants in the advanced trial to open label tenofovir and dolutegravir. Because there is a lot of talk around whether changing the regimen will cause a reduction in the weight that was gained. So what I interestingly found that in the women who were changed from TAF to TDF, there was significant reduction in weight of up to 1.6 kilograms. And there was also a favorable regression in metabolic parameter. But in the women who were changed from TAF to TTG to TDF and efavirenz, they further gained weight to up to 3 kilos in this group. There was not significant differences in the men. So changing the regimen is not the answer. Like multiple, I think people have reiterated, when you start a person on an INSTI-based regimen, I think lifestyle modification should be spoken of at the baseline to make sure that till we have solid guidelines or solid evidence to say what actually can reduce the weight in this cohort. So the lifestyle modification have to be the mainstay of advocacy in this point of time. As we go on from the weight gain, women seem to be, there are more data looking at metabolic fatty liver disease. Women, especially women more than 50 years of age, had a higher prevalence of metabolic fatty liver disease. And much has been said about the increased risk of MIs in women. So if you look at the risk of cardiac events in women, I think enough has been said and done that women seem to be more at risk at a younger age group. And also women who have cardiac issues are less treated than men, are less likely to be undergoing further treatment than men are. So there is this interesting study which was looking at the difference in the immune and inflammatory markers between men and women, relationship between the markers and the plaque. So what they found is that there was a low prevalence of any plaque with visible non-calcified portions and vulnerable features in the women. But women had an increased levels of IL-6, CRP, and D-dimers. And when they had increased levels of D-dimer, they had an increased level of plaque with visible non-calcified portions and vulnerable features. So, contrary to expectations, where you might expect that they have a higher incidence of atherosclerotic plaques and a higher risk of MI, women seem to have an increased risk of, do not seem to have an increased levels of plaque formation, but there is some other immunological or some other pathology which is actually making them more prone to cardiac diseases. And as in the study, you will say women had a high incidence echocardiograms done in this group of women where they had echocardiograms for LV function, LA function, and also the tricuspid regurgitation velocity. So they found like 5 to 6% of women had isolated maybe left ventricular systolic dysfunction. Some more had 6% had left ventricular diastolic dysfunction, and they had almost all of them had a high risk when they had lower CD4s. So this was an important data from Roy, which for the first time had a special separate session on mental health. So they classified people with HIV into 3 groups: high depression, low depression, and never depressed. And they found, interestingly, if you look at the TAF combinations, people in the high depression group only on TAF with boosted INSTIs or PIs were more prone to developing somatic effects of this depression symptoms. This was not seen in any other group. So they said the ART combinations rather than the individual drugs per se are responsible for these changes. We all know that women age, we see more incidence of malignancies in our cohort and in the patients in the clinic as such. And it's just to say, important thing to say that anal screening for anal carcinoma is very neglected in this group of women. And this is a data from a pooled analysis, and it included a study done in our clinic many years back. So where they had concurrent HPV typing from the anus and the cervix. So if you say that women with HIV in the anus, after 45, 55 years, older women seem to have a higher prevalence of high-risk HPV. And also another study interestingly showed that older women had a higher risk to biopsy-proven anal dysplasias and precancerous lesions. So this is an important group for screening of anal malignancies. I'd like to end with this very important study which associated with AMH and aging and reproductive aging in HIV-infected women. So this is a study with telomeres are nucleoprotein complexes that are markers of cellular aging. AMH is a glycoprotein which is developed from the ovarian follicles and a very sensitive marker of ovarian reserve. So what the study did is they looked at these two markers in two groups of women who were negative with HIV, without HIV, and also in the younger age group and post-reproductive age group. So what they found very importantly in this study is, I think, with implications for further care of these women, that women with HIV in the younger age group did have normal levels of AMH, but they had they had 20% lesser percentage of AMH, and also they had a very rapid drop of AMH starting around 35 years of age. And in the younger age group, HIV status by itself was a predictor of ovarian reserve and reproductive aging. And in the older age group, probably cellular aging and markers like the telomere lengths were probably a better indicator of aging and ovarian reserve. And this is very important. When this could mean that the delaying pregnancy could mean difficulties in conceiving and an earlier onset of menopause with all the compounding and following train of issues surrounding it. So this, in context of the evolving fertility desires of our women, it is very important that we are aware of the changing of the impact HIV itself has on so many systems and how it affects and translates into clinical care and health. So this is where we are and how we were compounded by the epidemic, which if you see 55% of women in this group said that they had impediments to accessing care because of the COVID pandemic. These are the priorities set up by WHO for women, and I think this is applicable to women with without HIV. Thank you.
Thank you, Dr. Kunduman, for telling me which is important topic on women's health and along with their HIV management. Thank you.
Next, we'll move on to the second lecture of today's morning. May I call upon Dr. Dinesh Kaul, Neeraj Jain. He'll be talking on self-care in health.
Teachers, thank you for inviting me for this important conversation. I want to also welcome all of you who have come from different parts of India to Delhi. And thank you on a Sunday morning for all of you for being here. I think it's an important conversation to have. I think Dr. Bangulari put forward some really interesting facts, and I was listening very carefully. I'm going to try and just go a little bit 20,000 foot high on a helicopter and try and talk a little bit about self-care overall. It's going to be more general, less specific on data. But really, what is self-care? And I think this definition is absolutely critical. Self-care is a comprehensive, people-centered, rights-based approach where people should have the right to be able to access care on their own. World Health Organization actually has defined it very well that to promote health, prevent disease, maintain health, and cope with illness and disability, with or without the support of a healthcare provider. I think that last part is extremely important. And what we saw in COVID was very interesting because we actually were overwhelmed. The whole system was overwhelmed, not having enough healthcare providers out there for COVID, and we saw that in the studies that Dr. Bangulari presented. So it's important that we are able to build this whole ecosystem of self-care if we want to deliver quality healthcare to the country, especially in a country like India, where a lot of people, 1.4 billion, I believe, on last count, were dispersed all around the country, difficult, hard to reach areas. And of course, we have the economic disparity which exists also. So what self-care will actually do is really focus on being able to provide us to get to SDGs 3, 4, 5, 9, 10, 12, and 16. So if we want to get to our SDG goals by 2030, self-care is going to be absolutely critical. I think in the health field, we would apply self-care a little bit more broadly, especially in sexual reproductive health, and talk a little bit about that. The challenge also is that a precondition for women to participate in self-care is that women need to have a voice in it. That's probably a little bit of a missing factor. They need to have a capacity to speak and be heard, ability to make decisions on their own, that needs to be figured out, and also free from violence, retribution, or fear. So there's a larger social determinant that we need to probably work on. Now, for the development of the agency of self-care in sexual reproductive health, I think it begins at puberty. And there are unequal power relationships, as we all probably are aware of. How are we going to work around that is going to be very, very critical, especially in adolescents and rural women. I think that area needs a little bit of focus. The WHO has recommended for self-care interventions where women use, where women can access usable, accurate information to inform them. And that again is a missing piece that we need to work on. For women's autonomy and control over their sexual reproductive health, there have been a lot of new and improved solutions that are out there, while also expanding existing alternatives that are available. Self-administration of injectable contraception, for example, or what we call SAN and breast globally. New versions of the contraceptive vaginal ring, use of oral contraception, and new fertility awareness methods. So a lot of this will have to be worked on. In the context of self-care, PATH is making consistent effort for a digitized, automated, integrated, decentralized, and monitored range of services on wider health issues. So not just, of course, limited to sexual reproductive health, but across the board. Self-care is going to be the way forward. I think we made a fair amount of success during COVID on COVID self-testing and also self-care post when the cases numbers were very high, on diabetes management, hypertension management. But this is an area, sexual reproductive health, that we need to really work on. For sexual reproductive health, I think we've been adapting health innovations with and for women across systems, population, and geographies. We think about it as a rights-based approach, informed by evidence and embedded in practical solutions, which also help us to enable align product technologies, information, and services to be able to deliver on that. Subcutaneous DMP, which I just mentioned, or DMP-SC, is a very, very innovative injectable contraceptive. I must say also that the government of India has now approved this product in its basket of family planning products, and it can dramatically expand the choice for women and adolescent girls when offered as a part of the broad mix. It's very easy to use. It's a self-injectable, actually, probably to start with, will be administered by healthcare workers, but it is in many countries used as a self-injectable. And it's a simple addition to delivery channels, because both in the public and the private sector. We have a partnership with JSI called the DMP-SC Access Collaborative, which is providing data, technical assistance, coordination, and tools to ensure that women and adolescent girls across the country and across Africa, across Asia, have equitable access to self-injection. It's part of the family planning mix of more than 50 countries already, and of which 30 of them are offering it as a self-injectable across Africa, Asia, Latin America, and Europe. And as I said, the government of India has recently approved this as part of its basket. Through a user-centered approach, PATH also developed the SILS diaphragm and the women's condom to non-hormonal products, methods that expand options for women initiated. So women initiated is important, because here the decision-making is actually shifting. So for women initiated contraceptive prevention in consultation with women, their partners, healthcare workers, researchers. We developed the SILFS diaphragm, which is now commercial. It was launched as Kaya by a company called Kessel. Self-testing, another big area of work that Path has been very involved with. I'm sorry to constantly talk about our work, but there are some very interesting solutions that we've been working on as Path. So recently we completed a dissemination of, and I'm sure most of you know this, dissemination of HIV self-testing demonstration project, which provided 93,000 individuals across the country the experience of HIV self-test kits. These included both blood as well as saliva-based kits. Path has also initiated Hep C testing in India and Vietnam to understand the acceptability and usability of the kits. Path further works on COVID self-testing kits, especially amongst healthcare workers and medical students, looking at repeated periodic use. So that's another area where we've been doing a lot of work. I think the challenge is going to be of regulatory. And I would just like to call that out that there are many self-testing solutions which are currently in the regulatory system, especially in India. And we probably need to find a way of moving them out faster. The project team really focuses on cost. So we have to bring costs down if we have to increase access. It has to become affordable. And these kits need to be available also in the commercial market while it goes into the health system, but the commercial market is an important part of the distribution channel. Just to close, my clock is not working, so I presume my time is scheduled to be over. So just to close, Path is envisioning that by leveraging the use of technology, self-care should be extended to the reach of rural masses. It should be equitable. Health equity is at the core of everything that we should be doing. It should be across health services, both social and covering social, economic, and gender. It should be in the public, private, both available. It should be affordable, as I have already sort of stressed on. That is what is going to increase access. And this technology-driven self-care solution, or these technology-driven self-care solutions, will be sustainable, will be comprehensive, and will reduce the burden of healthcare in our kind of settings, and especially in a situation where we do not have the number, the qualification, the type of healthcare providers that we probably need to serve a population the size of ours. Thank you so much. Thank you once again.
Thank you, Dr. Neeraj Jain, who has in detail told about self-care in health. Next, we'll move on to growing with HIV, impact of newer ART in pediatric HIV. May I call upon Dr. Dinesh Kaur to deliver his lecture.
Thanks a lot. Most of the HIV gatherings we have smaller. It is area of interest. Everybody wants to listen. We have to move from the lab to the bedside and to the social aspects. So what I will give an overview of what we have seen. We have really, as pediatricians, we see children growing. So that's what we have done, and we have evolved over the years with HIV from being a really deadly epidemic to a manageable, treatable disease with which people are living. So thanks a lot for inviting me again. In next 20 minutes or so, I'll try to give you about the dimensions of it. This is the scenario in Africa or India. To see in 1990s, we are to advent of anti-retroviral. Children with malnutrition, wastage, cachexia, social discrimination, social isolation, delayed diagnosis, lack of ART because there was just hardly anything in 1994. Anxiety. We used to see a lot of immune compromised children, TB, PCP pneumonia, tumors, non-Hodgkin's lymphoma. I have let children die with HIV and non-Hodgkin's lymphoma at that time. I will not do it at this point. And orphan children in the United States. This was the scenario, but the scenario has completely changed. So we see malleable children. It may be now criminal not to treat a child or a person with an HIV infection. The orphan, the deaths, what we had over the years from 1990 onwards to 2010, which were substantially increasing deaths and this means orphans. One of the parents had died. That means by 2009, 2010, 19.17 million children had lost their parents. Subsequently, with the antiretroviral therapy, this number has substantially come down, but still we are having a lot of deaths. So how did this scenario change over the years? From 1987, 1990, 1994, in pediatric HIV was the breakthrough, where we saw that just perinatal cytopenia using pregnant women could substantially reduce the risk of perinatal transmission to babies. So possibly this was the landmark study. About 67% was the transmission risk reduction. So they thought, no, this is a wonderful strategy to use. So all pregnant women should be screened in pregnancy. They should be given antiretroviral therapy, one drug. In 1994, subsequently, we have come to almost just not just one drug, we have to use triple drug therapy. Then what the data has shown, what the evidence has shown, what our clinical experience has shown. So most of the women, at least 75% of the pregnant women are on antiretroviral therapy. This is the scenario what we had in 2010 with the pediatric HIV formulations which were relevant with us, the vitamin, stability. This we have been using right from 1994 to something like 2010. And so the government was really emphasizing on nevarapine, but in the pediatric, in the private setup, we're definitely using better drugs, which had a better outcome with protease inhibitors. But over the years, we have changed. This regimen has also, this is just what we're using in 2020. Now, newer antiretroviral therapies have come from 2010 onwards. They are being used in the pediatric age group, especially the protease inhibitors like ritonavir, boosted, doranavir, ritonavir, just been more or less this phased out. But then we have to back up on bicyclovir. I don't think it's really a relevant Indian scenario for the pediatric. About it's approved for FDA for 12 years of age. But dolutegravir, yes, I think the government had the sensibility and to look at the data that dolutegravir is the drug, the one pill regimen could be used in the pregnant population and to the pediatric population, and it has made a difference over the years. This is the scenario in pediatric age group, less than 7.4% of the children are still infected. Population was this pediatric population in 2017. So it is very unfortunate to see children with HIV infection because of blood transfusion or because of, while I have not been able to find out whether both the parents are negative, the children are not sexually abused. So where does it come? It comes from the system. So there is a sort of somewhere they have got the HIV. So that's what we need to rectify. Now, what is new in the pediatric HIV management? As I said earlier, that we are using dolutegravir-based regimens in the pediatric age group that has made a difference, that has changed their outcome, their growth pattern, their susceptibility to different infections. They live longer and they have less infections. So we have a lot of these fixed drug combinations. We have some further newer bicyclovir, M-tricyclovir, tenofovir, but this is not available present in India. So let's hope we have this, the last one, the third combination available. Bicyclic works very well in adult population. So this is the regimen what we are using in the pediatric, what is approved in the pediatric. Okay. So from birth to 14 years, we are concentrating on using 2.5 TIs and ranitidine, and subsequently, this is about children with 6 years of age, they are more or less like an adult regimen. So these are the guidelines from the updated guidelines from DHSS in Jan 23. So this is what we are using, and what more or less the Proteus guideline. I'm not really sure why the lopinavir has been phased out, so it's not really available. So I been used to work nicely with the Proteus-based regimens. Now, what is the impact of liver antiretroviral agents? What we have used. There is a reduction in transmission, drastic reduction. You don't get to see children with HIV infection from mother to the baby if the mother is on accommodation. It's less than 1%, maybe even 2.1%. There's a change in the growth pattern of the height, weight. The moment they are started on antiretroviral within 2 years, I'm sure the data they have an upstart on their weights, on their heights. It has led to improvement in their survival, reduction in their morbidity and mortality, their quality of life has improved. And obviously, the number of pills has decreased from 5 to 10 pills to just about 1 to 3 pills. So early initiation of ART has better outcomes. The disease burden of opportunistic infections has decreased. So let's talk about how the mother to child transmission has drastically reduced. So antiretroviral medications have drastically reduced the perinatal transmission from about 8.3%. If we are using a single drug, it will be less than 1%. I have had not any child if the mother was a triple drug combination to get an HIV infection. So that's the beauty of treating the pregnant women with antiretroviral therapy. Irrespective of, obviously, they do have some side effects, they do have problems, but the baby is definitely safe, the perinatal transmission. This is the old data, how we have evolved. I got this figure specifically from Dr. Rashid Burchett's book. Somewhere where we were using just one drug, zidovudine, then 2 drugs, then one thing got emphasized was just single. They thought nevirapine was the magic, just one dose of nevirapine to the women and to the baby, but it's not the ultimate. So we have a lot of other drugs, triple drug therapy. That is the modality to ease the perinatal transmission. Now, earlier, one of the speakers told about the risk of mother to child transmission. This is a summated data from different studies. What is the transmission for breastfeeding? So if with antiretroviral, if 1 drug, 2 drugs, 3 drugs, and with or without breastfeeding. So US people are not recommending breastfeeding, but as a developing world, we are concentrating on using, we are emphasizing because breastfeeding may have to some extent some benefits. So if you see between the last 2 columns, 2%, 1%. So if with breastfeeding, the risk of transmission is about 2%. If the mother is on triple drug combination, with no breastfeeding, then it drops to 1%. So it's your option. In your scenario, if the mother can afford affordability to the formula feeding and it's clean, it's possible, it's feasible, then that's worthwhile. It is, you have to give them an option. What do they want to do? The growth pattern has definitely changed. So the growth pattern has changed over the weight and the height gain has definitely increased with antiretroviral. 2017, about 80% of the pregnant women, 59% of adults, and 52% of children had access to HIV medication. So this is the, but still, it's very unfortunate that still you have a lot of global deaths. So the growth pattern in HIV has definitely changed. They have less malnutrition, less short stature. Chronic diarrhea has substantially decreased because they don't get very bad diarrhea once they are on antiretroviral therapy. And their growth, because the virus affects the growth in a multi-modality fashion. I'm not putting the details. That has been completely taken care of. So if you see, this is a very nice study from Journal of Pediatrics, Spanish journal, where they have shown prior to ART what was the rate and the height percentiles minus 1.2 standard deviations, the Z scores. But after 2.4 years of initiation of ART, it has drastically shifted, both in the developing world, both in the developed world. So it does make a difference. And with opportunistic infections, if you look at the opportunistic infections, you'll see the opportunistic infections have in 5-year period in each group decreased from 60% to about 3.4. So this is the Western data, but this is applied to India also. Unfortunately, I don't have a substantial data to get you here regarding the opportunistic infections in the Indian population. So the overall rate of opportunistic infection has drastically decreased from 60 to 7.2 per 1,000 person years if you use triple drug antiretroviral therapy. So that has made a difference. And what we are seeing, common opportunistic infections in India, what we're seeing earlier, they have drastically decreased over the years. So we don't see a lot of PCP pneumonia, because most of the children, if they're infected, they are put on septal prophylaxis. So that has been the change. But we are seeing a lot of atypical mycobacteria. I had few children who had atypical mycobacterial infection, which unless and until we don't diagnose them microbiologically, so we put them on conventional ATT, they will respond. But we see less of cryptococcal meningitis, disseminated cryptococcal infection, but it is still there. Over the years, it has substantially decreased. So obviously, the initiation of early antiretroviral therapy. So if you see this CHERT trial, where they used early at first year of life, they were diagnosed, or you would wait till the CD4 counts were decreased. So this 2008 study was a landmark study published in the New Journal, where they said that no, the infants should be started first year of life. If you diagnose, you put the infants on triple drug therapy. So there is a drastic reduction to the deaths in the deferred group were more as compared to non-early initiation of antiretroviral therapy. So those are the lessons for us that we should be really taking the upfront, treating them, being very proactive with the antiretroviral management. So let's hope that this child grows and we give him happy days ahead. Thank you.
Thank you, Dr. Dinesh, for making a remarkable presentation and giving us hope that yes, curing infection among children is possible. There's also an announcement to make that at 11 a.m. there will be a photo shoot for conference conference picture. So I request you to be present at the hall and bring along all the friends, whoever is missing right now. So I would also like to thank all the presenters for keeping up on their allotted time, and want to invite Dr. Neha Mishra from Bangalore for presenting on the topic of caring adolescents with HIV. Thank you.
Good morning, everybody, and thank you very much for having me here. So today I'll be taking you through a topic on how to care for an adolescent who is moving from the transition or who is transitioning from pediatric to adolescence. So, there are several challenges when it comes to adolescence, and caring for LHIV is a sequential process. It's multimodal therapy that we should all combine and give it to the patient. Now, see, all the children who are suffering from it or who are just entering adolescence, they suffer from a lot of problems. They have stigma, they have shyness, they're not aware of a lot of facts They're probably scared of talking about it to anybody. Sometimes they just don't know how to handle it. And these are the statements that I took from the Journal of International AIDS Society. That this article was published in 2021. It has very heart-wrenching kind of statements given by a lot of children who are suffering from HIV and moving to adolescence. So one of them I have put up here, that stigma made me feel so bad, especially in family, that it came from a best friend. I even done this tried to commit suicide twice, but I failed that as well. So things like this, they keep going on a child's mind. And if we don't support the child rightly, we may, lose a bright future of our country and for of the world as well. The challenges, adolescence itself is a challenge. It comes with new cognitive capacity. Child has evolving decision capacity, struggles for, they are trying to go independence. They have a lot of questions in their mind coming up here and there. They want to sort out a lot of issues. They want to identify themselves with peers. They also need their own self-image, preoccupation with self-image. And they have, at that age, they also have their risk-taking behaviors. So, and when we talk about HIV is a problem in 2020, 1.75 million male HIV were seen across the world as per UNICEF data, and it accounts for about 5% of HIVs. In India, estimated data has around 1,900,000, and it was in 2017 data, and it was picked up from millions. So HIV-associated stigma and discrimination is also not unreal. It's something very important, and people do get trouble with this now and then. Children who suffer with, it is a chronic illness which requires a lot of treatment. Long comorbidities are present. They have a lot of adverse socioeconomic things to deal with. So it is a problem. Transmission of HIV in children can be vertical or horizontal, and both come up with their own challenges. It is likely to be in advanced. If it is vertically transmitted, they're likely to be in advanced stage of HIV, more likely to have OIs. They have growth and developmental issues, higher mortality rates, they might have lost their parents, and they have multiple HIV-related issues as well. And stigma, of course, as I said, is a very important factor. Earlier stage, when we talk about horizontally infected adolescents, they are usually in the earlier stage of HIV, although OIs are less, but they do suffer with stigma later, which can be exacerbated by stigma related to drug use, sexuality, etc. And they do not have good social, familial, or parental support most of the time. So I think caring for HIV comes probably 4 strategies. We have to look at the psychosocial support, education, both otherwise and sex education, general health and nutrition, and treating HIV. You have heard a lot about treating, and you will be hearing about immunization next time. So psychosocial factors, what does it comprise of? Increased likelihood of adverse family and social environment support, difficulty in the fact that they have it, the difficulty in accepting the fact that learning and coping to their diagnosis is also a problem, increased mental stress and risk of acquiring deviant and aggressive behavior, higher chance of hindered education and career related. So they have to be settled. That also is a problem in fact most of the time. Higher chances of coping up with the relationships or sexual practices, unwanted pregnancies are all the problems of HIV. Stigma and discrimination, I feel, is the biggest challenge. So factors associated with adherence of ARTs, they can be patient related, they can be environmental, they can be treatment related, or they can be caregiver related. So I think child related factors we have spoken about, but caregiver related factors, sometimes caregiver lack adequate understanding about what HIV is and how will they help the child. They have misconception about the disease, health beliefs which are not right, daily routine and nature and timing of the job. It's a monotonous thing to do recurrently every day, and also attitude towards the adherence of the medication. Repeated changes in the caregiver can be a big problem in relationship with the child as well. So this is a study I picked up from HIV/AIDS research palliative care, and it showed how a caregiver can also suffer a problem. So treating HIV or addressing care of HIV is not only a single-handed thing, it affects both. So an ALHIV affects the child and also the people around the child. So they have seen the main source of caregiving to ALHIV is the parent, and when the family is involved, problems are not limited to caregivers. So they have fear, guilt, societal thoughts, challenge, stigma. They also have these problems which they have to deal day in and out. So again, what I mean to say is the problem is not limited to the child. The social structure also has to be strengthened in certain ways. This is another study that showed. So how do we deal with it? So how to disclose it to the parent, how to disclose it to the family, how to disclose it to the child may play a very important role. If you read the national guidelines of India for HIV management, it actually tells you how step by step we should introduce this information to the child at each particular stage when it is diagnosed. So when the child is maybe a 3-year-old child, what to tell to them. When the child is older than that, what to tell to them. So each of these things should be told to them in a sequential way so that they adopt it properly. Disclosure on clinical outcomes among young children. This is a Kenyan study where Kenya doesn't have a proper disclosure. At this point in time, they didn't have proper disclosure guidelines. So you can see these are the patients who were aware of the infection and who were unaware of the infection. See, loss to follow was people who were aware of infection, loss to follow was 18 people out of 214, and people who were unaware, the dropout rate was around 158 people, around 201. So dropout rates were clearly very high in a patient who were not aware of their disease. So disclosing it properly may make a huge difference in patients can accept their disease better, they can treat themselves better, they can understand and learn to work around it, because at that point they're new brains, they're learning still. So what we teach them will probably what they'll adopt and learn and move forward. You can see here, again, it's not only related to adhering to the facility or adhering to the treatment plan, it is also related to mortality or death. So people who were disclosed early, you can see this dotted chart. The number 251, the hazard ratio for death was very high. The people who knew, who did not know about the disease because probably they did not adhere to the treatment. And similarly, the hazard ratio was lower for the people who were told about the disease and probably they understood the nature and importance of taking the medication and could retain into the facility and take a treatment. So knowing their HIV status was associated with reduced mortality, reduced loss to follow-ups. So how do we communicate? Communicating is a very important part of this whole exercise. Whenever we are talking to a child, I think it has to be a very comprehensive talk. What we should do, what we should avoid should be always kept in mind. We have to be truthful to them. We can't hide everything. We have to be updated ourselves to teach them what we are trying to tell them. We have to use proper words and concepts. We can use flip cards or you can use a pictorial version of it to explain them better. Treat them with respect. You cannot just, scare them away or tell them in a way that they won't like it. Give them all information, choices, and help them to decide what to do. So it should be their choice. It should be probably you should start treating them partially as adult at the time they meet you because they are already entering into adulthood and they are trying to understand the world better with the present understanding of others. Treat all the adults equally. You should not discriminate between one another. Be understanding, supportive, accept that they may choose to show their individuality. That's absolutely fine. I think that should be enough. Giving them inaccurate, information, threatening them, giving them only information that they will understand or they may not understand. So I think we should tell them everything. Talking down to them, shouting, getting angry, blaming them, or telling them partial things, saying that you may not understand, you're too young to understand all this is not the right way probably to deal them or to communicate with them. Hence, we should probably try to communicate with them as effectively as possible in best possible way. So they should also have proper sexual education, growing up and changing behavior, sex and relationships, pregnancy preventions. We have to tell them about condoms, prevention of STDs. These things has to be taught to them properly because they may be shy, defensive, helpless, and a lot more things. They may not even understand what hormonal changes are going on because, as I said, adolescence itself comes with a lot of problems. So there are 5 ways, as again, in the national guidelines. We have to assess, we have to advise, we have to agree, we have to arrange assist. So assessing their physical mental status, giving them treatment or what they're taking, assessing that part of it, assessing their social structures, support structures, and knowledge, belief, concerns regarding HIV may help us in making a better treatment plan. Advising regarding any inaccurate knowledge or beliefs they have, you have to fill the gaps. You have to advise them regarding relationships, sex, alcohol, drug use, sexual activity, condom use, contraceptions, everything that we think that may help in promoting their mental and sexual health is also important. Where we have to agree where the adolescent choose their, it's fine if they want to take their treatment at particular place. Again, it's fine if they don't want to tell it to somebody that they have maybe. It's again fine how they want to wish or whom they want to tell, they don't want to tell. And you have to make sure that the goals are set in a way that they reflect adolescents' priorities, not yours. So we do enter, or caregivers or healthcare professionals do enter into adolescent care with certain goals, but then we must understand that goals should be helping them, not us. So assisting them to provide a written and pictorial form, as I said, treatments and medications, fundamental contraception, skills and tools, so that they can. We have to also build up the child so that he or she can support himself as he move forward in the future. So we have to provide them skills, provide them knowledge, education, help them with that as far as possible. And it has to be understood by the whole social structure altogether. One person cannot be doing it all. Again, we have to arrange if they, the next visit whenever we are meeting them again. And we have to also tell them to, meet referral group counseling or reliable support. I think it is required. So this is another study published in Journal of International AIDS Society, which quoted that trauma probably gives rise to. Trauma can be of any form: disclosure, diagnosis related trauma, severe illness, death of caregiver, sexual abuse or violent assault. It could be intimate partner violence, family conflicts, neglect, abuse, anything, any trauma. These traumas can lead to, them leaving the care, moving away from the facility, being lost to follow them. That should be avoided. And how do we deal with this? So healthcare worker can assess the trauma, sensitize, and relocate to think that particular place is not working out for the law enforcement should be taken help. You can take from employer whenever required. So these things can be helpful. Again, stigma and isolation, as I said, is probably one of the major, not only in adolescents, I think even for adults, it's one of the major problems that we still deal with. People are still reluctant to come to the healthcare facility, wanting to take more treatment or staying in, retaining them into the facility. They may come to you for diagnostic purposes, but retaining them into the facility is still difficult. It is very problematic. We still struggle a lot to kind of counsel them, tell them that, see, you just have to take one pill a day and you'll still be okay. Then, so stigma, we have to deal with it as friendly as possible. It can be peer mentor kind of a relationship. You can have support groups, you can have advisory boards, etc. So these things can be done. Again, we have to strengthen their social structure as well as far as possible. Look at if there is any repression or suicidality in the background and try to treat that. If required, you can take psychiatrist help, psychology referral, etc. And gaps in the care for abandonment of care. All these things which I stated above actually may lead to gaps in care. So they have to be treated and tackled. So when they are transitioning from pediatric to adult care services, if there is a specific protocol in place, so to some extent, Indian facility does have a protocol, and they do tell us how to go about it. So specific protocol during the transition is helpful in improving the clinical outcomes as well. Again, important part is nutrition, because poor nutrition status is related to the HIV directly, impaired immune system. Then it may lead to make them more vulnerable to infections, and increased nutritional needs due to malabsorption, etc. That may be there. So we have to tackle them depending on their age. We have to provide them with good nutrition, etc. Tell them, along with the medication counseling, we have to also tell them that what is the need for additional food, why they need dietary modifications, safe food preparations, about safe food and water storage methods, and hygiene issues should be also there. So to summarize, I think I have not gone into ART and vaccination because they have already been covered. So I think the time is also to summarize all this. I think ALHIV care is also, it's not a single person's job. It's a group thing. We have to probably 4 or 5 people like ID specialist or pediatricians and nurse, counselor, all these have to come together, sit together, formulate a structure for the child, and then help them move into the society so that they can navigate with confidence and make themselves a better person, be more accepted by the society. So with that, I will end my session. Thank you very much.
Thank you, Dr. Neha Mishra, for delivering lecture of important topic of adolescents with HIV. The counseling alone will do much to all our HIV patients. We have to be very patient with dealing with all such issues which are, it comes as the single, we keep on tending to so many HIV patients. So we will have a better option in doing proper counseling, which will go long way in curtailing the spread of this HIV/AIDS. Thank you very much. Madam.
Thank you, sir.
So the last presenter for this session will be Dr. Ruby Mansal, the topic of immunization. Right, so there's a change. Like to invite Dr. G.D. Ravindra for deliberating on ethics in introducing newer drugs. Okay.
Thank you, ma'am. Good morning, everybody. This change in progress of the talk that we are talking today is, my talk was just before lunch. And so I thought we should talk about Sir Radhakrishna's quote on philosophy. He said, bounty of nature yielded more food. Man was relieved of his hunger. And then he started talking about philosophy. And my talk was just before lunch. So I thought this would be an appropriate thing to say, that you people will not listen to what I'm going to talk about. Radhakrishnan also said, a life of joy and happiness is possible only on the basis of knowledge and science. Now, when we talk about HIV and ART, we know it works. We have the Lazarus effect, which showed that there was an improvement in patients with the ART. And we also know death rates have come down because of ART. If ART is so effective, why do we need new drugs? Now, when we talk about this, when we need new drugs, you look at the number of pills and the medications that people have to take. They have to take pills for a long period of time, and there is no cure as of today for HIV infection. The second important thing is we have is the side effects of these drugs, which can be very unpleasant and which may make people lose their faith in medical care and in the hospital for now. Hence, there is a need for new drugs. And when we talk about new drugs, the most important thing is that we should have something to cure HIV. And when you say, what do you mean by cure HIV? A regimen of intervention capable of completely eliminating HIV from the body or inducing a state of durable ART suppression so that there is small quantities of HIV present in the body, but not actively increasing to cause immunological damage. So this is the ideal pursuit that we have for cure of HIV. In addition to that, we need to reduce the lifelong treatment period to a shorter duration, reduce toxicity, reduce cost, reduce barriers to access, and reduce social stigma and discrimination which occurs because of proper use of drugs. And lastly, there are adherent challenges for which we need newer drugs. Now, when we talk, how can we achieve it? We have the conventional drugs. We have new drugs that have been manufactured, off-label products. We have repurposing of drugs. We have gene therapies. We have stem cell therapies. We have immune-based therapies, early intensified HIV treatment, latency recovery, changing agencies. And remember, a single intervention may not alone result in cure. We need to have multiple interventions for effective system eradication of HIV. And lastly, we have alternate and complementary medicines, which also many of our patients use and for which we need to know about it. Now, whenever we talk about a drug development, it's a costly process And according to that, it goes through various stages. And according to the FDA, it takes at least 100 million to $1 billion before a drug can come into the market. And it takes approximately 12 years. And the success rate is very low. Only 1 in 5,000 compounds is approved after human testing. So it's a very big business which needs a lot of effort and time. And when we talk about the ethical issues that we talk about, we always base our talk on principles of biomedical ethics, which was principalism, which was talked about by two philosophers, Bisham and Childress in 1955. They identified 4 important factors that are necessary for treatment or management of any patient. And this has been the mainstay of all that we are talking about. We talked about benefits, that is, whatever you do, the drug that we use will benefit the patient. And we need to assess the risk, which is to prevent no harm to the patient. It should be risk-free. Then we talked about justice, that it should be equitable and everybody should get it. And lastly, we talked about autonomy. Now, when we talk about autonomy, it means they have a right for self-determination, and it's an integral part of respect for persons. Patients will be treated as the independent persons who are capable of making their decisions in their own best interest. And if they are not capable, we need to protect them. In healthcare settings, high care personnel must respect patients' rights to make decisions and abide by the decisions that even if it is against what we believe in. And to this, we have respect. And one of the important parts of respecting a person is getting obtaining consent. Consent is a mutual sharing of information. It expresses the respect for the person. It gains patients' active involvement in their care. It respects patients' rights to self-administration. All of us have obtained consent in our practice. And when we ask for consent from the patient, he or she will not do it to you unless she or he discusses with the family and friends. So this has been one of the major reasons, which is a criticism of principalism. It is American in nature. It takes an individual. It does not take into account the cultural background of the people. So because of that, it also has a formula-like approach. You stick each box, and if it is all the boxes are ticked, it is right. So there is another philosophy which is circulating in medicine. That is the question of values. Values or virtues. Values are described what people believe to be important to them. Values are recognized as a driving force in making decision making. All of us make value-based decisions even in our day-to-day life. It will influence the kind of decisions that we make, and certain values have to evolve, which are cross-cultural. For example, cleanliness is a cross-cultural phenomenon. If you are in Kerala, you can have bath 3 times a day. It's hot, humid weather, and there's a lot of water that is present. But if you are in North Asia, where it's so difficult to get water, you may have the bath once a week. And if you are in Iceland, you may use large liters of heat. And if you are in first countries for the advent of their prosperity, they would use cents to keep themselves clean. So culturally, and these values are the same, whichever culture we go into. So it becomes important when we are talking about patients and dealing with them. And this has led to development of 2 guidelines which have been used for medical research. Now, when we talk about values and research, we talk about 4 important values, just like 4 principles. One is care, to feel concern and affection or consideration for the patient. Respect, this includes the first 2 principles, that is, of doing the best for the patient and not harming the patient. Respect and honesty is the 4th principle of the 3rd principle of autonomy. You have due regard for customs, wishes, and fairness, which is the justice principle that we talk about. Using this, we have a whole lot of guidelines that have been there. The advantage is it takes into account the welfare of those who are affected. It also takes into the cultural context in which research is being done. And when you talk about virtue aspect, remember, we respect the individuals that they can pick and choose what they want to do. They can make judgments about what is particular medications are indicated and appropriate and safe, and we can give best care, requiring knowledge and experience that we have with our patients. And there are almost 9 guidelines and 1 law which controls drug trials in our country. And if I were to talk about all these guidelines and laws, it will take one whole week for my people to discuss. So I will not go into it. But the what I suggest is that you look at guidelines, the first guideline, 271, 2017, National Ethical Guidelines for Biomedical and Research involving human participants. It gives us a detailed account of all the things that we need to do in when you start doing research. And this is a law. And if you break the law, you will be punished. So it is very essential as researchers that we know this law. And this law has been amended and the latest rules have come in 2022, which I speak to us in the end, which is important for us when we are dealing with humans. Now, when we talk about ethical dilemmas that happen with new drugs, we talk about patient selection, we talk about placebo trials, we talk about treatment interruptions, early clinic year studies, end of life studies, and vulnerable populations in relation to our drug trials, that is women, children, and AIDS, repurposed drugs, unapproved drugs, Ayush formulations, and several medicines. Now, there has been a change in the way our patients have been getting enrolled into the study drug trials. In the early phase of drug trials, it was easy to recruit patients because that was the only way they could access drugs which would prolong their lives. But now, with the advent of ART, all patients are stable. And if they have to enroll in the study, they must have something more than necessary to get enrolled. And usually, people get enrolled are people who have significant side effects. People are afraid about taking lot of drugs. People are paid ART non-responders, but widely not suppressed, incomplete immune recovery, patients with cancer, patients of salvage therapy, or at the end of life periods. And we, as ethics committee people and have to protect vulnerable patients in these drug trials. Now, when we talk about this, important thing is use of placebos. There are a lot of questions. There is standard should we use placebos? And now the consensus is if it is scientifically needed, we need to use placebos when we are doing studies. The other important thing that we talk about is treatment interruptions. If you have a patient who is virally suppressed for a long period of time, you ask him to stop treatment and see how he responds to the withdrawal of the drug and whether he has. So one of the problems that we have is they may have developed retroviral syndrome. They may have increased risk of HIV transmission to their partners, which again can be mitigated. The partners are taking temporary exposure prophylaxis. Now, risk benefit size, ethics board, we need to assess the risk benefit issues that are there. And immediately the risk benefit, what is the type of anticipated risk, the background standard of care. Some will not be possible to capture in short term clinical trials. So we have to be very careful when we permit treatment interruptions. Early phase HIV cure studies are exploratory with little or no likelihood of being cured. Currently, no established for in early phase HIV cure. We need the risk of interventions, monitoring procedure, and what mitigation strategies study will have for patients who fail the treatment. When you talk about decision making to participate, there are three. There is therapeutic misconception, therapeutic compensation. Confusing the effect of research, therapeutic misconception, overestimating the probability of bonus misestimation and therapeutic compensation. We always hope that there's a positive outcome in patients. And usually patients make that decision based on what is thinking to respond. Lack of consistency, the extent of therapeutic information. And this all depends because patients have trust in the clinical practice. And because of chronic nature of it, they have long established relationships with particular clinicians, and that influences who they make decisions. And ethics boards have to be very careful that this is not being used to influence patients to participate in trials. Then we need robust preclinical data, we need those limits, and we need patient data. So that they recognize that the social benefits, enhance benefits to the individual, and build societal benefits for this. Informed consent is important, and it should be communicated to a potential participant here. It should be clients and the correct information, right information, high level of action. Standard should be given to all potential participants to really understand the key features and the degree to which participant motivations to enroll in include benefits, high risk this which is altruistic motivated should also be assessed. End of life research is a very important concept to recognize new theories and new ways of dealing with it. And we have gift of life study which is going on in US. They have end of life people have higher risk for research and translation research that can happen. And usually the society benefits because which would be large. This knowledge would result in finding better cures for change. And to the participants, it's a deep meaning because they feel that they're contributing something to the society by donating their bodies after they die. And consent should remain with the study for the participant throughout the treatment. And they may have scientific risk because they are small samples and they may not be generalized with the results that we get. Women in HIV trials is very important. And Dr. Pongri talked about it in the morning. And I highlight the other arm of the pregnancy, different and pregnancy, where we cannot do direct studies only by having resistance and collecting. Then pediatric HIV research is the only consequence that is there. The therapeutic interventions are not recommended for children under 2 years. For those that at least 2 drugs are not involved in these trials. Then we have older adults. This is the last mistake. We talk about it. I want you to look at this. For academic purposes, repurposed drugs have to get permission from the ethics board, and the institution has to take permission. The institution has to take responsibility for providing care if there is something goes wrong. Whereas marketing agencies, they go to the regular process of getting studies being done. But off-label use, if the clinician that you have, it is at the discretion of the individual doctor, but you need patient's consent. This is a new class that has been introduced more probably because of the COVID that came about to protect the doctors when they are using the repurposed drugs. When compassionate use the drug cargo is allowed, now with this serious work, it says the purpose of using this drug should be intimated to the institute grounds. And if you are in government service, you should get permission from the government. And lastly, the patient consent is very essential. New drugs have approved elsewhere can be imported with special permission from the CDS. Height formulations are there, and it's a major thing that we talk about today. And we have very good guidelines which have been written. There are 3 volumes of it, which covers each aspect of it, and it has to be done by GCP. We also have herbal medicines, and it's important because patients will use herbal medicine now and then, and they may interact with ERT drugs that we are giving. So we need to know about them also. And what we need to do is protect our people from ethics. This is the term that is used when research is moved from an high to low as science and society, ultimately on exploitation. Thank you.
Thank you, Dr. for clarifying the introduction. You are next. Now the floor is open for the discussion.
Is there any question from audience? The speakers will. Okay.
Thank you.
Thank you, Dr.
Thank you very much. I will request now the chair to felicitate our speakers. Dr. Mungoli, Mr. Neeraj Jain, Dr. Dinesh Kaul, Dr. Neha Mishra, and Dr. Ravindra. I request Dr. Kumar to felicitate our chairs. Now we will move on to our next session. That is strategies in pipeline for cure of HIV. I will invite chairs for this session. Dr. Rahman Sarkar from Dhaka, Dr. G. Samara from Vijayawada. And we have a very important topic in this session, triple elimination of MDCT, HIV, syphilis, and viral hepatitis. I will request the chair to introduce and invite the speaker.
I am expressing my thanks to all. Firstly, I request Mr. Pauline Don Organization. Please give comments to the organization.
you very much and a very good morning. I see some very familiar faces. So today I'm going to talk to you about triple elimination of mother to child, or we can call it vertical transmission of HIV, syphilis, and viral hepatitis. So I'm going to cover today about what is triple elimination of mother to child transmission, why we should do it, how to implement it, and some experience globally and in other countries, and a bit of a summary as well. In May of last year, the world had the World Health Assembly, and they endorsed the global health strategies for HIV, viral hepatitis, and STIs, all in one document to work towards achieving the SDGs. Now, the SDGs are 6.5 years away. Last year, I said we are 7 years away, but now, today, we are 6.5 years away. So we don't have a lot of time, but that means that we can still do much and rebuild from the COVID pandemic. I'm going to remind you what is validation, because validation is a process that WHO does, and we do it as a certification to member countries recognizing their achievements. Elimination as a public health problem for HIV, for viral hepatitis, for STIs. It's about reduction of disease incidence, prevalence, morbidity, or mortality as a result of efforts to reduce below a level at which the public health burden is considered negligible. The target level for a particular disease is generally defined globally by WHO. So when reached, even if you're certified, you need to continue the actions to maintain the reduced level. And then what is validation? It's an independent confirmation of elimination as a public health problem that attests and documents that a country has successfully met the criteria for elimination. And we have a whole host of experience globally and in India. We have eliminated, for example, polio, yawns, so many diseases, malaria, all diseases on the elimination, TB, there is validation, or the country is moving towards validation of elimination. HIV, achieving 95 is just a step towards ensuring that we reach and we eliminate the public health burden. And in elimination of mother to child transmission for HIV, syphilis, and viral hepatitis B is no different. Why do we, and why does WHO and the world advocate to have triple elimination? Because all these three infections are transmitted sexually and vertically from mother to child, can cause significant maternal and child morbidity or mortality, is often silent, and infected mothers are unaware and have no symptoms, and can be identified during antenatal care, treated, cured, and to prevent vertical transmission. No child today should be infected or growing up with congenital syphilis, for example. We are in 2023. No child should be living with HIV because we have effective drugs to prevent and be prophylactic as well. No child should be living with viral hepatitis B because we have effective vaccine and we have hepatitis B immunoglobulin at districts and below. So no child should be living with all these infections that are preventable and treatable. Now, the triple elimination criteria of WHO is really about helping countries think through and finishing the last mile of vertical transmission. And it is the latest guidelines came out last year, and it is really about having 0 new HIV infections, less than 50 cases of congenital syphilis, by live births in 80 countries, 80% of countries by 2030, and in children, less than a 0.1% hepatitis surface antigen for infection among children aged 5 years by 2030. So all these are doable. And I will talk to you more around the hepatitis part because you are all experts and you will know a lot about HIV and STIs. But essentially, triple elimination brings together all the different approaches and to get it coordinated and delivered as an integrated service delivery by the maternal and child health platform. So we look at different targets. We have the strategies. There's impact targets, which is on infections and case rates and prevalence. And then we have programmatic targets, which is about coverage of services and reaching the women and child and making sure that no one falls through the cracks. There are other foundational assessment areas for WHO validation of elimination. This is on programs and services, whether public and private provide high quality antenatal services, whether services are accessible, available, acceptable, affordable, with high coverage of antenatal care. We look at laboratory services and whether there is quality assurance and whether there is a unified data system that can capture data from both public and private sector and can detect most cases of mother-to-child transmission. We look at human rights and make sure that there are some basic human rights principles and gender equality that is supportive of legal and policy framework for women and men. Now, I'm going to talk to you more about elimination of viral hepatitis B and C, because this is usually in an AIDS conference such as this, you are now all actually experts of infectious disease and HIV. I'd like to tell you more a little bit on hepatitis B and C, as the public health response in viral hepatitis B and C in India is still pretty new. The national program started only in 2018. Guidelines were disseminated in 2019. The last COVID-19 happened in 2020-21, and we tried to rebuild back in 2022. So it is a rather nascent public health response. And this is something that all of you can be involved. Because you understand HIV and viral hepatitis is similar as a blood-borne infection. So there are 5 core interventions where sufficient coverage will lead to elimination, including a 90% reduction of incidence and a reduction of mortality by 65% by 2030. You will see that there's a few interventions that range from ensuring a 3-dose hepatitis B vaccine to hepatitis B prevention of mother-to-child transmission, ensuring safe blood and injection safety, harm reduction for people who inject drugs, and of course, hepatitis B and C testing and treatment. So these tell you a little bit more, but the service coverage targets for the viral hepatitis B is to ensure that at least there is, by 2030, a 90% hepatitis B 3rd dose coverage. And by 2030, prevention of mother-to-child transmission, vaccination, and other approaches to prevent mother-to-child transmission of a hepatitis B 3rd dose coverage. So imagine, today India stands at 92% institutional delivery. 20 years ago, it was impossible to imagine. Today, NHM, with the delivery of services, assures 92% institutional delivery rates. And that means 92% of all these women should have integrated antenatal screening for HIV, syphilis, and viral hepatitis B. South Asia
and I'm borrowing this data from my colleagues from the regional office. Southeast Asia bears a significant burden of HIV, hepatitis, and STIs. We have estimated a 60 million chronic hepatitis B, 10 million hepatitis C, there's 500,000 of new infections, and more than 200,000 deaths annually due to hepatitis. In HIV, we had in 2020, there's an estimated 100,000 new infections and 82,000 deaths. So new infections and deaths are still really high. And for STIs, there are 60 million infections of 4 curable STIs. Although there's a decline, it still represents a really huge burden of viral STIs. And let's look at the Seattle progress towards viral hepatitis elimination. And this is pretty similar across the whole world. In vaccination for hepatitis B, because universal childhood vaccination has been around for many years now, 3 doses of completion for hepatitis B is pretty high because you have now the pentavalent and hexavalent vaccine. But if you look at the primary birth dose, it's quite low still in most of Southeast Asia. And that is the crux. To prevent vertical transmission of hepatitis B, you need to ensure really high rates of the first dose, which is the primary birth dose of hepatitis B within 24 hours of delivery. So you can see that in hepatitis B PMTCT, which is the birth dose, the Seattle region is only around 34%. So we still have a lot of work to do. But listen, there's a discrepancy, don't you think? If we have 92% of women who are coming from institutional delivery, why are they not getting the first dose? That is something to think about. We have pretty good blood safety and it's getting better. Injection safety has changed. We need a lot of work around harm reduction and needle syringe exchanges and oral substitution programs. For testing and screening for both for hepatitis B and C, it's still really low. We just have a very far ways to go. And for treatments, it's still very low. Despite having South Asia and India having universal free access to Hep B and Hep C treatment down to the sub-district level. The testing, the National Viral Hepatitis Program has made testing available even at primary care center level. So of course, different states are in different stages of implementation, but these are all opportunities that we need to make use of as clinicians and as champions for infectious disease. In Southeast Asia as well, we are missing the gap. Southeast Asia as a region did not achieve the 2020 targets, and we're still quite far away from the 2030 targets too. Now, let me come to implementing and how do countries implement triple elimination. It is an initiative, it's a vision, it seems doable, but what does it actually mean in working across the different healthcare programs at state, at city, at districts? Triple elimination of vertical transmission puts the mother-to-child health at the center of services, irrespective of which programs work on guidelines, work on strategic plans, it still puts people at the center of that service. That means that at the end, the RCH program under National Health Mission is the one that provides the services and ensures the health of the mother to child across the continuum of care. This is written in a strategic plan. And the other infectious disease specific programs like NACO, like NACP, and like National Viral Hepatitis Control Program, They work on all the program elements to ensure guidelines and updated guidelines, the monitoring, the data systems, the drugs, the test kits are available so that the other programs can use it and make sure that the mother and child are not missed. When I say leave no mother and child behind, what does it mean? As you know, India has around, I think, an estimated 23 million births. We have to ensure that at least all these births get HIV, syphilis, and viral hepatitis B screening. In some areas, maybe a hepatitis C screening, because hepatitis C is also transmitted particularly from mother and child, particularly in where the background prevalence of hepatitis C or injecting is found. And then they have the standard antenatal follow-up for obstetric care. But you have a subset of that infected mother for HIV, syphilis, hepatitis B or C, where you say, okay, if we have to confirm the diagnosis, there is specific intervention per disease, there is managed care for the pregnancy, but there's also managed care for the mother and the child as a multidisciplinary approach. There's a joint care by a trained medical team, whether it's the doctor, nurse, midwife, and others, for the specific infectious disease. So, for example, in the hepatitis B continuum of care pathway, all of you are very familiar with management of HIV and syphilis detected in antenatal care. But for hepatitis B, it's actually pretty similar as well. Detect, screen, confirm, then manage the woman like any other infectious disease. Make sure that the baby has a timely birth dose within at least within 24 hours. And then there's postnatal care. And then for the baby, a completion of the other 3 doses of pentavalent, hexavalent vaccines over the first year of age. But there are also additional interventions that can be done for the mother, including assessment and clinical staging of her hepatitis disease. It's a thing like HIV. We do that as well as clinicians. Like ensuring there's a viral load or at least a hepatitis E antigen to see whether she is viral, assess the liver function, whether she has cirrhosis or not, and then determine how to manage her. It's the same. So the approach is the same when you have a woman who has any infectious disease, because it's about managing her and managing the baby too, and ensuring the baby is prevented from vertical transmission. And of course, for the baby, there is hepatitis B immunoglobulin, which is now free and accessible in all states in the country. So a little bit of a revision why addressing hepatitis B mother-to-child transmission is important, because, and this is, I think, is a very, very old, and this is what we know and is standard knowledge. When a child is exposed to hepatitis B at birth, more likely, if you see the dark line on top, more than 90% of these babies exposed to hepatitis B at birth will get chronically infected. And then as the child reaches the age of 5 years, less than 10% of them will get chronically infected. Chronic infection is the crux of it. So if I say that I was exposed as an adult and I'm not immune, most likely I only have a 10% chance of being chronically infected. But for children, the imperative and why we do timely birth dose and completion of hepatitis B vaccinations is to make sure children are not infected with hepatitis B as a young child. And we see it, of course, with cirrhosis, with liver cancer and death. And these are all premature deaths that are completely preventable with the vaccines at birth. So today, the approach for prevention of hepatitis B at birth in the first years of life have evolved, that evolved beyond immunization. Why do I say beyond immunization? Because very many people still do not know this, that you can go beyond 3 doses of vaccines. And for the women who are tested to be hepatitis B, they can be provided additional interventions, including antiviral drugs. I know that I'm going forward, but let me just finish my name. So the risk of hepatitis B transmission for women who have high viral load. The most simple is hepatitis E antigen positive pregnant women is if you do nothing, 70 to 90% of the babies will be infected with hepatitis B. If you give a vaccine, it will be about 20%. If you give immunoprophylaxis, the risk goes down. And if you give antiviral drugs, then we really can get to almost zero transmission. And that is a crux, because aside from the universe of hepatitis B positive mothers, they are actually within that a subset of mothers more at risk. And these are the pregnant women who are hepatitis B infected with high viral load. So EMTCT services are also the entry point to better health for all, for entry points, for prevention, and also to integrate other services for hepatitis, for TB, and for STIs. If I may, Chairman, could I go through the slides for the guidelines and also other countries? So let's go on, and I'll try to finish this quickly. So I would like to let you know that WHO guidelines are new. And in July 2020, there is a guideline on antiviral use for pregnant women for hepatitis B, AMPCT. And there is a whole guideline that talks about the tenofovir safety for mother and infant, for efficacy of preventing transmission, and using a proxy for maternal DNA viral loads, and when to treat, how to treat, what to treat. But very importantly, we also have experience from other regions and countries as well, and how other regions are moving forwards towards triple elimination, because this is really a low-hanging fruit. This is a place where you can afford, you can give mother an integrated 3 test, whether it is a dual test, HIV, syphilis, plus the hepatitis B test screening. But what we do see in the Western Pacific region, and these are data that has been presented in many conferences as well, is that as long as you have institutional delivery, your birth dose should be high. It can be delivered as long as there's institutional delivery. Where countries have very low institutional delivery, birth dose is low. That makes sense. And in the Western Pacific region, most of their countries in blue have been verified to reach very, very low, very low targets, and which means that they're very high coverage of vaccination already, including for the first dose. So I'm going to skip on. In the progress of many countries in the Western Pacific region, you can see that in 2017, as a baseline, not very many countries had any movement around hepatitis B. They just really worked on HIV and syphilis elimination. But in 2021, more and more of these countries worked on the third elimination, the third E. And today, most countries, including high-income countries such as Australia, Malaysia, the middle-income countries, they're all working on different parts of elimination and trying to strengthen the additional interventions for hepatitis B elimination. So every country has its own story, but it's important to keep on moving forwards. Let me tell you a little bit about how China moved on. China has a very unique background. There is a 99% vaccine coverage, there's 96% primary birth dose, a 99% hepatitis B birth dose, 99% happy use, and 99% antenatal care. But they could not still reach the 2030 target, not ahead of time. But if they use tenofovir at a high coverage, that target could be reached by 2025. So what it means, if China were to put in tenofovir as an additional intervention, they can prevent new children from hepatitis B. Even if it prevents 100,000 children a year, China is 1.3 billion people. But if you can think about it, 100,000 children prevented ahead of time by 5 years. That means that you're saving 500,000 children by 2030 from hepatitis B and the risk of liver cancer and a lifelong infection of hepatitis B. We have worked with China on many things and to move it forward. And we have to move on to make sure that we coordinate among all the programs. And that's where you come on, because you sit at state, you have a strong advocacy voice. The guidelines are there. We can do demonstration, it's feasible. So in 2022, 17 countries are validated by WHO for elimination. And in the next few years, we will have more countries that will add the third E into this as well. There are a few operational guidelines that will be useful, including the ones from the Western Pacific region. There are tools, there's modeling and cost-effective analysis that are all available, publicly available on the WHO website. There's projections of how to get in the scenario-based modeling that can help countries moving forward. But the key summary is this. It is an initiative that centers on health of mother and child. Guidance tools available. It's operational, feasible, but at the end, it can be achieved. We are now in the era of the last few years of the SDGs. We have to optimize, leverage, converge, and integrate. And I want to say this because I've known Dr. Gilada for a very long time. We have all collectively made the art of the impossible possible. So elimination is not impossible. It is possible. Thank you very much.
Thank you very much, Dr. Pauline Jan, World Health Organization, for our nice and smart presentation. She describes the elimination of obesity, so I have nothing to say for we have satisfied for the last presentation. Thank you.
Thank you very much. Thank you, chairs. Thank you, speaker. So I will request our chairs to felicitate Dr. Pauline Chan. And simultaneously, I will request George sir to felicitate our chair. And please stay back in the hall. We'll have the group photograph.
That's it. That's it.
Okay.
If anybody outside, please to come to the hall. We will have a group photograph just before the tea break.
Okay, yes, please looking for. Okay.
It's fine. Okay, this is a continental state. It's okay. Want a cup of tea? We can get you one. Sure. Is that because we don't?
Thank you. Hello?
To make a presentation on a very important
Good
subject.
afternoon, we are now starting the last session of the day. I would like to invite here. I would like to invite chairs for the session. Dr. Richa Diwan from Delhi. Dr. Sunita Kataria from Gurugram. So now we will start our presentation. I will request chair to guide the speaker. Afternoon, ladies and gentlemen, welcome back to the afternoon session, pre-lunch session. This is the last session of the day. And it's an interesting session with wide variety of topics. And one of the interesting topics that we're going to go ahead with is this online breakfast of this talk. It's by Dr. Sanjay Pujari from Pune. The talk is on weight gain with integrity indicators. Is it a real threat? We all know love drugs on the web.
Everybody at the outset, let me thank Vilada for inviting me to make a presentation on a very important subject, the issue of weight gain with integrase inhibitors. Unfortunately, I couldn't be there, so I'm doing this online. So this is the outline of my presentation. First, we'll try to look at the problem of weight gain and the complexities associated with encrypting data. If there is weight gain, what are the consequences, both metabolic as well as comorbidity consequences? And finally, let us explore if we have some solutions to try to mitigate the weight gain associated with these drugs. So first of all, we need to understand that globally and particularly in India, we are living in this obesogenic environment. And in general, people are getting weight, and this is the National Health Family Survey data, where you can see over these years, there has been a dramatic increase in the proportion of individuals defined as overweight based on BMI criteria, both in men as well as women over these two calendar years. So importantly, we need to realize that people are getting overweight, and we are having a population which is very susceptible to comorbidities associated with this weight gain. Now, when you initiate antiretroviral treatment, we have always knew that there is always an increase in the proportion of people who gain weight, whether you want to look at it in terms of median weight gain or weight change, or even if you want to look at it in terms of the proportion of individuals developing obesity or overweight. After initiating any form of antiretroviral treatment, we know the proportion of people going into higher weight categories like obesity and overweight increases. The reason for that is what is envisaged as return to health phenomena in which the catabolic state associated with HIV disease is reversed, and this leads to weight gain. And consistently low CD4 count, high viral load, and normal or low weight at ART initiation has been associated with increasing weight irrespective of the ART regimen that we have been using. However, randomized controlled trials, pooled analysis with modeling data in the developed world has demonstrated that the weight change which happens with integrase inhibitors is much higher than as compared to boosted protease inhibitor or NNRTI over week 96, whether you look at it as a weight change, which is roughly around 3 kgs at the end of 96 weeks, and an absolute weight also increasing more commonly in the integrase inhibitors as compared to NNRTI. So this was the first signal that it's possible that you have weight gain increase happening because of integrase inhibitors. And then amongst the integrase inhibitors, the further data looking at the same data set demonstrates higher weight gain happening in individuals initiated on bictegravir or dolutegravir as compared to the older generation integrase inhibitor of levetiracetam. So it looks like contemporary ART using second generation inhibitors have this risk of excess weight gain happening. But if you actually look at mean weight changes over 96 weeks, we are looking at in the Caucasian population somewhere around 4 to 5 kgs. And this is not really a good indicator when you talk about mean weight changes. Whether those mean weight changes are clinically relevant is not a good indicator really to assess the consequences of that. A better way to look at is the proportion of individuals progressing in their BMI or the proportion of individuals developing more than 5% or 10% weight gain above their baseline. So what about bictegravir in antiretroviral population as shown here in the Gilead 8, 9, and 0 studies? After initiating a bictegravir-based regimen, you see weight gain happening to the tune of around 5 kgs at the end of 240 weeks. What is important for us to look at is most weight gain seem to happen in naive populations in the initial 48 weeks. So around 1 year, you have the maximum weight gain happening, and subsequently there is a gradual weight gain which happens. And we'll show you certain data subsequently of the trajectory of weight gain in long-term exposure to integrase inhibitors. Then is there data from low and middle income countries? This was the first signal coming from the advanced trial, as you all know, was a randomized control trial in African population, where individuals were randomized to the dolutegravir versus efavirenz 600 milligrams, and the dolutegravir was paired either with the TAF or TDF. So as you see here, there has been a significant weight gain happening in the TAF regimen when it is combined with DTG, followed by DTG when it combined with TDF. And finally, not much significant weight gain as compared to these two arms in the efavirenz 600 milligrams arm. Again, as you may see here, most weight gain is happening initially over the first 2 years, and then there is a gradual weight gain which continues to happen over the subsequent periods. So this is long-term data, the final analysis at week 192. Again, if you look at gender differences, this is a female population having substantially more weight gain, African women as compared to male. And the reasons for these differences in weight changes happening on indices across gender is still unclear. As I said to you before, rather than looking at mean weight changes, it may be interesting to look at how many proportion individuals develop obesity. And as is shown here, in the female population, in the TAF DTG arm, you will see time to obesity significantly faster as compared to the TDF DTG arm and efavirenz 600 milligram arm. This difference is not very great in this African male population. So again, gender is a very important issue, particularly both from the developed and developing world as a risk factor for gaining weight in integrase inhibitor initiation. The NAMSA study final 192-week analysis presented at Montreal last year also demonstrated that you have weight gain happening in the TDF DTG arm as compared to the efavirenz 400 milligram arm. And again, I would like to notice that the weight gain is initially very rapid at around up to 48 weeks, and then there is kind of leveling off or a gradual weight gain happening subsequent to 48 weeks. If you want to look at percentage of people who, this is the data in females, specifically looking at proportion who gained more than 15% of baseline weight. Again, you see here the proportion is higher in the TDF 3TC DTG arm or the TLD arm, as we now call it, versus the FRS 400 milligram. Now, what happens when you switch? In the switch situation, the return to health phenomena is kind of eliminated. People are on ART for a long period of time, and for some reason, for convenience or tolerability or cost, you may switch these individuals to an integrase-based regimen. So, based on pooled analysis of 2 ACTG trials, what is shown here, this is the data prior to switching the weight changes. Prior to switching this modeling studies, it is a predicted weight change. And over a period of 2 years subsequently after switching to INSTI, there is overall an increase in weight which has seen. But again, what I would like to notice is if you're looking at the absolute values, we're looking at around 3 to 4 kgs of weight gain happening around the 2 years. So the important thing is, again, when we try to delineate which of the integrase inhibitors are associated with this, you find aldegrave is not as much, but it is predominantly a dolutegravir, the second generation integrase inhibitors, along with bictegravir, that have been associated with a significant weight gain post-switch from a stable biologically suppressed ART. In the same study, as you may see here, looking at where you gain weight, it looks like when you switch from a boosted protease inhibitor, the weight gain is not very great as compared to when you switch from an NNRTI to an integrase inhibitor. So as you can see here, the difference in the weight gain along with the 95% CIs, when you switch from PI to DTG is still significant, but it's about 1 kg per year of weight gain. And when you look at switching from NNRTI to DTG, it's about 1.5 kgs per year weight gain. So it looks like the signal is when you switch from an NNRTI to an integrase, like what is commonly happening in our practices today, is switching from TLA to TLD. So you're switching from an efavirenz to dolutegravir. You may have a higher incidence of weight gain happening in this context as compared to somebody who's stably suppressed on a second line boosted protease inhibitor, where you switch to a dolutegravir based regimen based on the 2SD study data. You may have good virologic response and not very great weight gain happening in this context, but this needs further research in our own setups. What about 2-drug treatment with an integrase inhibitor? This is pooled analysis from the Tango and the SALSA, specifically looking at weight changes over a period of 48 weeks. And as you see here, when you switch from a TAF-based regimen to DTG 3TC, there's not much difference in the proportion in the change in the adjusted mean weight, which happens. But when you switch from a TDF to DTG 3TC, you see there is an increase in weight which happens, which goes up to about 36 weeks and then subsequently plateaus off as compared to continuing the same regimen. And in abacavir, you see a similar thing. So what this essentially gives you a signal is that perhaps we are looking at, when we said NNRTI to DTG, we talked about perhaps there is a weight suppressing effect of NNRTI as compared to say PI. And in this situation, you can see here there is perhaps a weight suppressing effect of TDF. When you switch away from TDF, that suppressing effect goes off. And when you give an integrase inhibitor, that with some direct effect may be associated with weight gain with integrase inhibitors, cumulatively leads to weight gain in this setup. And this is the real world data. So I already said to you the mean, analyzing mean weights can be tricky. So we look here at proportion of individuals gaining more than 5% or more than 10% weight at 12 months based on as compared to baseline. Switching from an NNRTI or continuing the NNRTI to integrase inhibitors. So as you see here, a proportion of individuals gaining weight more than 5% significantly increases, and so it increases the 10% category. If you look at across the integrase inhibitor class, against the signal is that second generation integrase inhibitors tend to gain when switching a proportion of individuals with 5% and 10% with bictegravir and dolutegravir more commonly than elbiterravir. Now, programmatically, we know people have been moving away on a large scale in Africa and even in India. Now, people are moving away from TLE to TLD. And this is some data preliminary from African setups, which looks at weight changes post TLD transition. Again, this is a modeling study based on the data collected. As you can see here, prior to TLD, this is stratified according to males and females. This is the weight trajectory which you see there. And subsequently, when you shift to TLD for a period of 2.5 years, there is a weight gain happening. And this is particularly seen amongst females. Again here, as you see here, when you switch from baseline regimen to a TID regimen, what you switch for as far as the core drug is concerned may also determine how weight gain happens. So when you are switching from say efavirenz, you will see a weight gain happening in that context. The weight gain is maximum in naive patients, and in some proportion of PI patients, the numbers are very small in the study to make a final conclusion. But even after PI switch to integrase inhibitor, you may see weight gain happening. And when you want to look at the clinical significance in terms of increase in BMI, the same is reflected for females after transitioning to TID. But as you see here for the PI, the BMI can get negated. So we saw a rapid increase in weight happening after PI to integrase inhibitor switch. But when you look at it in terms of clinically relevant endpoint like BMI change, you do not see much when the PI is switched to integrase inhibitor. But from efavirenz to integrase inhibitor, there is a possibility that switch is happening. So the gain of weight that you may see in integrase inhibitors happens in a proportion of individuals. Not everybody has clinically significant weight gain. Some, and I show our own data subsequently, and the proportion of individuals who gain more than 5% and 10% weight gain is significant, but not, it's heterogeneous and not everybody really gets it. So this is our own data. This is unpublished yet, but under the review partly I'll show you some data where we looked at people transitioning from TLE to either TLD or TAF or TCTTG. And this is prior to switch. Again, we use linear mixed models to assess this. So you see here the weight gain is not very, very significant prior to switch. And then subsequently over a period of 1 year, there is a rapid weight gain which happens overall in both the arms. And then there is a slow progression of weight gain happening. If you look at the slope of this slope after 1 year versus the slope of this, they're quite parallel. So most weight gains seem to happen within 1 year of switching from TLA to TLD. And obviously TAF is a bigger risk factor. So when you switch along with TAF, you have a higher weight gain happening. This is average weight as compared to switching to a TLD based regimen. Again, in females in India also, in our clinic, there is a signal that weight gain is associated on switching to integrase inhibitors more commonly in females as compared to males. And finally, a low baseline CD4 count at switch is also associated with higher weight gain as compared to the CD4 categories of 200 to 500 versus more than 500. But better to look at is the proportion of individuals gaining weight 5 to 9% and more than 10%. And as you see here, this is the incidence rate ratios in both the arms in our data analysis, where when you combine it with TAF, there is a higher incidence rate ratio, which is clinically significant when you switch to TAF FTCTG as compared to TLD. But it's not that TLD, you don't see weight gain happening, incidence of weight gain happening in these categories. It is still happening, but it is higher when you combine TTG with TAF. And whether you look at it as 5 to 9% or more than 10%, the incident rate ratios are quite significant in terms of comparing TAF with TTG versus TLD. So there are risk factors for weight gain. As I said to you before, these are not homogeneous. There is a population amongst whom you initiate integrase inhibitors have a potential to gain weight gain, have a potential to gain weight. And these are some of the factors maybe which may be associated with weight gain. We already saw low CD4 count. So somebody is switching or initiating at low CD4 count has a higher weight gain. As also somebody who's viremic has a higher proportion of weight gain. Somebody who has a low weight or a low or normal BMI also has a higher risk of weight gain as compared to somebody who's already obese at baseline in terms of trying to further worsen obesity. After switching, it's unlikely. It's more people who are normal weight or low weight who actually gain weight. African ethnicity, female gender, we already said, has a higher risk of weight gain, which is there. So the practice consequence of this is that there is a certain pool of population in your practice in whom you're either initiating or switching to integrase inhibitors. Carefully monitor the weight in these individuals with low CD4 count who are switching for failure or who are females or who have a lower normal BMI at switch. These are the individuals more likely to gain weight and have some metabolic consequences associated. So we talked about efavirenz and TDF having weight suppressive effect. So it's still unclear whether this weight gain is secondary to direct effect of integrase inhibitors, particularly in terms of switching it's very, very important to understand that when you switch from TLE, you are potentially switching two drugs from the previous regimen, which are maybe associated with the weight prevention of weight gain, that is TDF and efavirenz. And this is in the advanced studies that demonstrated that extensive metabolizers of efavirenz, which are associated with low efavirenz plasma levels, have weight gain similar to dolutegravir. So this kind of tries to prove you the association that efavirenz probably is associated with a weight suppressing effect. And in terms of TDF as well, when you switch from TDF to TAF, keeping the core agents same, and this is data from the OPERA cohort, you can see here there is weight gain happening in the integrase inhibitor arm as well as the NRTI arm, and to some extent the PI arm when you switch the TDF to TAF. Now there may be a direct effect of TAF on weight gain, which will be there, or there may be a removal of the TDF suppressive weight gain effect. So this has been further seen when you actually look at PrEP trials where you use TDF or TAF-FTC. And what you see there is that weight loss is associated. Now, this is a healthy population. This is not HIV infected population. They're not switching from anything. But when they measured weight, and this is a pooled analysis, meta-analysis, and the forest plot shows you overall, when in the context of PrEP, when TDF is used, there is some weight loss that is seen. So clearly, the one component of weight gain is the inhibitory effect of TDF and efavirenz, which does not lead to significant weight gain in naive patients when initiated, or when you switch from TLE to an integrase inhibitor, you may have the weight suppressing effect being removed, adding to the additional direct effect of weight gain associated with integrase inhibitors, further amplified by addition of DAF. So now let us look at the consequences of, does this really cause problems? As I told you that, you have patients who gain 3 or 4 kgs of weight, but that is actually misleading. What is important is what proportion increase their BMI, as well as what proportion have more than 5% or 10% weight gain. So this is from the advanced trial as shown here. Most gain that is happening, as you see here, is fat gain. So this is 72% fat in the TAF-FTC ATG arm in women, around 70% fat, and even 90% fat on efavirenz and DTG. And same is true for men. If you try to look at where the fat is getting deposited in terms of measuring it in DEXA scans, you see similar proportion of total change of fat in the subcutaneous compartment and as well as the visceral adipose tissue. So limb fat, trunk fat, fat is deposited in both these compartments, whether you look across women or men. What happens in the switch scenario? When you switch and you gain weight, where do you gain this fat weight, whether it's in the visceral or the subcutaneous adipose tissue? And in this retrospective observational study where they did DEXAs, they actually saw that weight fat distribution is happening both in the subcutaneous adipose tissue as well as visceral adipose tissue compartments. It's important to understand the consequence of getting fat deposited excessively in the visceral adipose tissue, because we know that is associated significantly with increasing waist hip circumference ratios, as well as metabolic syndrome and its subsequent metabolic complications. And that is the reason why in the advanced trial, you can see the proportion of individuals overall who develop metabolic syndrome at week 96 was high. And now we have data also for 192. I'm not showing you that data. But females tend to have a higher proportion of developing metabolic syndrome when DTG is used with TAF. So is true when DTG is used with TDF, although at lesser rates. And same is true in males. So metabolic syndrome can be a consequence of integrase inhibitor associated weight gain. And its subsequent consequence can be the metabolic complication and comorbidities like diabetes and CV risk. So in women, if weight gain is so significant, this is data looking at weight gain more than 5% and less than 5% in the women's HIV study in the US, looking at the impact on blood pressure. So what you see here is in integrase inhibitor and non-integrase inhibitor group, when you have more than 5% weight gain, the instance of systolic blood pressure increasing. So this is very, very marginal, as you may see here, 2 to 6 versus diastolic pressure as well, maybe an independent effect associated with weight gain in integrase inhibitor treatment. And again, a very marginal small difference in terms of A1C concentration in the proportion of women who have more than 5% weight gain. There is a marginal increase in A1C concentrations as compared to somebody with similar weight gain in the non-integrase inhibitor. Now, this is interesting because there is now some evidence to suggest that perhaps integrase inhibitor, apart from weight gain, may have an independent effect on development of hyperglycemia and diabetes. This is where the NA accord comes in, where it's a really complex slide, but what it essentially shows you that the risk is slightly high of incident DM after integrase inhibitor initiation. And the total effect, the mediated effect of weight gain is slightly less than the total effect on incident DM, saying that weight gain is not the only, cannot only explain the higher incidence of marginally increased diabetes in individuals initiating integrase inhibitor, and perhaps indicating that there may be independent effect of that. This is a very interesting study. Within 6 months, they looked at integrase inhibitor incident diabetes and hyperglycemia. And you see here in primary analysis, 31% higher risk of incident diabetes happening with the integrase inhibitors, along with dolutegravir. So within 6 months, if you are seeing that weight gain is happening, but it is not very great, you are going to see weight gain happening over a period of 1 year. But even before people develop this high amounts of weight, there is an independent higher risk of integrase inhibitors associated with incident hyperglycemia. So the clinical consequence of that for us in our practice is to really closely monitor metabolic parameters in individuals who are initiating or switching to INSTIs in our own clinical practice. And what is the impact on dyslipidemia? Well, overall integrase inhibitor as compared to NLRTIs tend to have higher incidence of dyslipidemia, whether you look at it as either in the switch situation or in the naive population. So dyslipidemia is also common. Some of them can be mediated because of the weight gain associated with the integrase inhibitors. Based on all this, when you try to calculate CV risk based on various equations, and this is a study looking at Framingham, Q risk, and DAD, there's only significant increase in risk in the TAF-FTC-DTG group from baseline increase in CV risk, which happened with the Q risk equation, and not so with Framingham and DAD. Again, these are very, very minor changes. You can see the risk just increased by plus 0.2 for a 10-year period. So this is something which is still evolving. We really don't understand what are the hard clinical outcomes associated with integrase inhibitors, whether mediated through weight gain or not. But I would like to show you this data. This was a signal, but this is of course an observational study where they looked at hard endpoint or composite of cardiovascular events after initiating an integrase-based regimen. Obviously, this is prone to channeling bias, but what it shows you is that the incidence of CV events after initiating integrase inhibitors is quite high at around 6 months. And then subsequently, it tries to level off around 2 years and then goes down. This is interesting because what it shows you, of course, from an observational setup, that the rapid weight gain which may happen during the first year after initiating or switching to INSTI may not really account for all the metabolic consequences and the CV events that may be seen. So further research is needed to understand whether integrase inhibitors have independent effect on increasing slightly the incidence of hyperglycemia, diabetes, as well as CV events. And finally, liver steatosis is a big issue. We know that with weight gain, you will have fat in the liver. And this is a study looking at the risk of de novo steatosis. And as you see, our integrase inhibitors and TAF have a higher hazard ratio of being associated with liver steatosis, predominantly mediated through weight gain. And interestingly, the progression, subsequent development of progression is higher in the integrase as compared to the non-integrase based regimen. So these are all the consequences. This is still an evolving field, and more research is needed. And in India, particularly, we need to really focus on the Indian population because they seem to have a different fat distribution. Even in the general population, we all know the concept of a thin fat Indian, who looks thin from the BMI perspective, but has different fat distribution with predominant fat in the visceral adipose tissue in the truncal compartment. And then there is also the situation about ectopic fat around the pericardium, in the liver, etc., which also may be different in the Indian population. And the impact of HIV as well as integrase inhibitors on this needs to be further clarified in our own setups. Finally, let us look at whether we have solutions. We have understood the problem. There is some signal there that integrase inhibitors are associated with clinically significant weight gain. We also looked at some of the metabolic consequences, including hard endpoints like diabetes, hyperglycemia, and CV events and liver steatosis associated with the use of integrase inhibitors, whether mediated by weight gain completely or an independent effect, still unclear. But we have to deal with this in our clinic population, and that is how we need to look at it. So weight gain is a general problem in our clinical practice, in internal medicine practice. This is one of the most significant problems that all physicians face. So for that, we really don't have much data from the HIV specific situation. So we follow the data, which is with recommendations which are there for the HIV negative. So of course, lifestyle interventions include diet. And there are sub-studies in the HIV context looking at low calorie daily diet versus intermittent fasting, etc. Most studies are needed to look at the impact of reducing weight gain in this context. Physical activity, smoking, of course, avoiding. And now there are some trials looking at semaglutide, which is a GLP-1RA, which used in diabetes management, and also approved for weight loss. So there are some clinical trials already running in I think Patima's group in Ireland, looking at use of semaglutide to reduce weight gain that happens with integrase inhibitors in the HIV positive population. And finally, can we switch back from the integrase inhibitor back to our old efavirenz, because we saw that efavirenz has a suppressive effect, or can we move away from TAF back to our TDF so that can we reverse that weight gain? Well, this is the advanced studies further follow-up, where this is the study called Characterize. It is still ongoing, but it's a very small number of patients, as you can see, and stratified according to females and males. What happened in this is patients at the end of 192 weeks were offered to switch to TLD, all of them. When the TAF FTC DTG switched to TLD, there was a decline in weight which happened, switching away from TAF to TDF. In the TDF FTC DTG, there was a gradually progressive weight gain happening by continuing TLD. In the efavirenz group, when the TDF efavirenz TLE was switched to TLD, there was again a weight gain which happened, demonstrating that weight suppressive effect of efavirenz was removed, leading and an integrase inhibitor added while continuing the TDF in both the as a backbone, the weight gain happened. So this is one area of interest where more data is needed of switching away from so-called obesogenic or weight gain associated drugs to weight suppressive drugs, but we can't really translate it into clinical practice right now. Again, the numbers are very small in the Athena part, where they basically just looked at discontinuing only TAF or only INSTI and discontinuing both, but just 11 participants. So this was presented at CROI this year. But this data is very, very preliminary, but there may be a signal that if you switch away from TAF DTG or TAF to TDF at least, you may be able to see some gains being reversed, particularly in the first year as is shown in this study, but subsequent leveling up. So this is another area where we need to have a close look into in terms of studies. So in summary, I think contemporary ART, we were very happy that we had drugs which are simple, which had high genetic barrier to resistance, which were associated with potency, high tolerability, an unforeseen phenomena of weight gain is being seen with this integrase inhibitors as well as TAF. But we have to remember that when you read these data at mean weight, may not be really, it would be interesting to present that information, but the clinical consequence is more important. The proportion of individuals gaining more than 5%, 50%, the BMIs, and the clinical consequences of that is more important as compared to just looking at mean weight gains or absolute weight gains. Very clearly, second generation integrase inhibitors, especially with TAF, is associated with weight gain. We clearly don't know whether this is a direct effect, whether it is the removal of the weight suppressing effect, and more studies are needed in this context. Certainly, these clinically significant weight gain, the proportion of your people living with HIV who have significant more than 10% weight gain has definite metabolic consequences. both in terms of dyslipidemia, liver steatosis, incident diabetes or hyperglycemia. But this would need to look for a longer term data for the studies that needed to clarify this. But in our own clinical practice, we need to be very vigilant in trying to monitor for these events, particularly in those who gain weight very rapidly on initiating or switching to INSTI and manage them effectively at an earlier phase. And finally, interventions to address weight gain needs further research. And this is something which we need to really look forward. And maybe in India as we conduct research to address these things. So thank you for your attention. And, I hope you all are enjoying the conference.
Can move to the next talk. That is also an online talk. This is by Dr. Robert Scully from USA, who is the top infectious expert from USA, from University of California, San Diego. He is talking about emerging infectious diseases. So can we have the
Good morning and greetings from San Diego. I'm sorry I'm not with you at ASICON this year in Delhi. I hope your Sunday morning is going well. I've been asked to talk to you today about emerging infections, things that we have seen since the beginning of time and will continue to see moving forward. And I'd like to focus this mainly on lessons we've learned from COVID. I'm making some comments about influenza and close with things we need to think about moving forward. There have been a number of disease outbreaks over the course of the human history, going back many years before recorded history. These are listing only a few of the ones we've known about for the last millennium, starting with the Black Death in the 1300s. Over the last and more recent years, we've seen an increasing number of outbreaks and pandemics, not perhaps because they're more of them, but perhaps because we're more able to record them. And when they do get started, because of interconnectivity among global populations, they're more likely to spread. The most recent pandemic began only 4 years ago in Wuhan, China, with the emergence of a novel coronavirus into the general population of Wuhan, China. Since that time, the virus has moved around the world. Shown here the case rates in both the US and India, showing that in both countries we had a series of waves of infections that have occurred as the virus has evolved under selective immunologic pressure. Collectively, the US and India have accounted for about a quarter of the world's deaths. I suspect this is an overestimation because I think the enumeration of cases are probably better overall in the US and India than the rest of the world. But nonetheless, both of our countries have been badly hit by this novel coronavirus. Now, what have we seen with this coronavirus and with others? We start with often with pathogens that are endemic in the population, or that maybe get introduced to the population from outside species. And these will collaborate to become an outbreak under the right conditions epidemiologically. Again, depending on the relationship between the pathogen and the human populations at risk, this can expand to become an outbreak, from an outbreak to an epidemic, and from there to a global pandemic, which is what we saw with COVID. And what we're now seeing over the last 6 months is a gradual return to an endemic situation in which we have periodic low rates of COVID throughout the globe, and that will remain with us, we think, going forward. This has been the case with other coronaviruses that have entered the human population. So what have we learned over the last 4 years from SARS-CoV-2? Lesson number one is censoring unpleasant news can be deadly. This is Dr. Li Wengyang, who is an ophthalmologist who saw a patient in 2019 in Wuhan and found out that her family became sick shortly thereafter, as he did. He warned his colleagues on WeChat that there was a new respiratory virus circulating in the community and was silenced and censored by the police for spreading rumors. 2 weeks later, he was admitted to the hospital and died. This early warning would have given the Wuhan officials a bit more time to control the pandemic locally. And it's a good example of how local censorship can be a problem. Lesson two, the world is a small place. We first saw this outbreak in Wuhan, China, over a very short period of time. The outbreak spread throughout all of China and indeed over the next several months throughout the world. So we are very connected now, and there really is no such thing as a pathogen in one part of the globe that isn't intrinsically a threat to those of us in other parts of the world. We're all in this together. Lesson 3 is that when new infections enter the general population, we first hear about the symptomatic cases. These are the ones that come to the hospital, and mild cases stay home. And what this does is it causes us to overestimate the severity of the disease, but underestimate the spread of the disease. In the US, early on, we thought we reported about 6,000 cases of COVID through March, March of 2020. In fact, there were 7 or 8 times that that just had not been reported because they were milder, were not diagnosed, or did not seek medical attention. These more asymptomatic cases that we learned about later. Another important lesson is that we should be careful not to restrict our attention in finding new cases by looking under the lamppost. This is a case that occurred in one of our sister universities, the University of California, Davis. A woman who had not traveled to China and who presented to her local hospital, community hospital near Sacramento, with pneumonia. The physicians taking care of her were worried that this might be COVID, and they asked that she be tested for COVID. The CDC at the time was the only place that had control of testing kits, and refused to test her because she'd not been to China, and said this person couldn't have COVID. There's no Chinese connection. To make a long story short, she got sicker over the next several days, was found and transferred to the University of California, Davis Hospital, and through persistent pressure was allowed to be tested and indeed had COVID, but not until after multiple other people had been exposed in the meantime to this pathogen while testing had been denied because she didn't fit the case definition. Keep an open mind as we learn about new infections spreading in the general population. Another important lesson is that when emergency conditions come along, be careful about getting caught in bureaucratic regulations. When COVID came along, we didn't have a diagnostic test kit available for it. The WHO quickly developed them, but in the US, we were hamstrung by a bureaucratic fight between the CDC and the FDA about who would approve tests. Many academic labs had tests that worked, but were not allowed to use them in clinical medicine. The only tests that were available at CDC, and they were having trouble quality assuring and making them. While we had politicians saying everyone can be tested, in fact, very few people can be tested. It wasn't until the FDA released access to these tests, to laboratory developed tests, that we were able to test the population adequately. Lesson 6 is that public health decisions have to be made by science rather than by politics. As early as the end of January, Peter Navarro, a member of President Trump's cabinet, was making it very clear that this was a existential threat to the US and the world. This coronavirus infection, and we had no existing cure or vaccine, would leave us defenseless. Despite that, the next month, our president was on television talking about how a miracle might come along and cause this to disappear by April. This led to complacency on the general population and slowed our response to COVID as the virus spread among us for politically expedient reasons. Another important lesson is that we invested in science very quickly after that, and this is what turned out to have a major impact on the pandemic. First example was vaccine development. We've been working on an AIDS vaccine without success for about 30 years. But that work, the background of that work, laid the foundation for the very rapid development of an mRNA-based, highly effective vaccine against COVID that was deployed in the US within a year. This is something that is unprecedented in the past. It shows what can be done with modern technology. The second example is in therapeutics. Remdesivir is an antiviral that has been developed for other purposes, but has activity against coronaviruses. It was in clinical trials within several months of the recognition of the virus of the infection and was available to patients by the end of 2020. The final lesson is that we haven't been very good as scientists explaining to the general public what science is. We got caught a number of times in which we were oversimplifying the science of COVID and saying things like, once you get vaccinated, you never have to worry about COVID again. In fact, we didn't know that. What we should have said is this vaccine has been shown to substantially reduce the likelihood of COVID and also very substantially reduce the chance of being admitted to the hospital or dying of the disease. We'll know soon about whether we need to continue to vaccinate people over time or whether the virus will evolve. The failure to recognize limitations of what we know and to make it clear to the public that as we learn, which is what science is. Science is the pursuit and application of knowledge, with an understanding that as we pursue knowledge, it will evolve. We should engage the public in this search and have them understand that we tell them what we know now, we tell them what our uncertainties are, and we will tell them more as we learn them, and we need them as our partners. So what's next? There are many different possibilities. They include influenza, hemorrhagic fever viruses, Nipah, which we've seen in India, among other places. New coronaviruses, yellow fever, dengue, or something new. One thing that is clear is that there will be new pandemics moving forward, and we need to be prepared for them. Influenza in 1918 killed 5% of the US population, a much bigger impact than COVID had, and certainly something that could happen again. Influenza is a major threat for a couple of reasons. One is it's an RNA virus, which allows it to evolve quite gradually over time. But the second, it's a little trick that the virus has. Its genetic information is encoded in segmented pieces of RNA that can be packaged randomly in new viral particles as viruses are produced. And what that means is that if two different viruses, influenza viruses, infect the same cell, these genes can reassort themselves and totally new viruses can emerge. And that's what has happened over time as we developed these new strains of influenza, these rapid shifts of influenza that now have incorporated genes from avian flu, make it possible to create radically different strains of influenza that can infect the human population and other species. Avian influenza is something that we've known about for quite a while. It was initially recognized as foul plague, but found to be influenza A really only about 60 years ago, when it was confirmed that foul plague was influenza A. Since that time, we've learned that these influenzas move rapidly among bird populations, both wild bird populations and captive populations, and then they can also move into people. H5N1 is one of the several highly pathogenic avian influenzas that has been circulating, that has found its way into the human population. H5N1 was found in birds in the early part of this millennium, and within several years was found not just as it was initially located in China, but throughout the world, being spread by migratory birds that then infect local bird populations, including chickens. Humans can pick this virus up. This virus has been found in humans around the world. Over 900 cases have now been reported. The remarkable thing is the death rate in humans for recognized cases is about 50%. Now, luckily, this virus is, although quite good at being spread among birds, doesn't spread well among humans. And when you look carefully at the epidemiologic contacts of people with avian influenza, most of them have contact with poultry production facilities with large concentrations of what turned out to be affected birds. And you can see this overlap in China, that the poultry density in a given province is something that predicted the amount of H5N1 in the human population. The reason for that is that the tip of the hemagglutinin in avian flu prefers to grow in birds. And when it infects humans, it prefers to infect cells that are found down in our lungs, not in our respiratory tract. So it's difficult to get from birds, but when we get it, the virus gets into our lungs and causes pneumonia. Once it causes pneumonia, it doesn't transmit from person to person very well, although it can in hospital and household settings. So right now we have a virus that can be highly pathogenic in the lungs when we get it, but isn't very well transmitted. Our concern would be if this tip is able to evolve so that it is both able to infect easily the upper and lower respiratory tracts and combine the ability to spread rapidly with the ability to cause severe disease. We know this virus is present around the world. This is one of the, these are highly pathogenic influenzas in the US. The thing I want to make, what I want to make a case of is these viruses are not just found in birds. They're found in a number of other species, including cats, bears, foxes, and even sea lions. Influenza A is a virus that gets around among species. And this allows it to have animal reservoirs to come back between seasons, and it also gives it the opportunity to evolve. Clinical manifestations of avian influenza often include diarrhea, abdominal pain and vomiting, more often causing GI symptoms in the case of non-avian influenza, and the pulmonary symptoms we see that reflect the tropism, the virus of the lung, are also quite common. So where are we now? What have we learned? We've learned that we need to be very vigilant about the outbreak, about the emergence of new pathogens. We learned pandemics or pathogens are discovered. Transparency is critical. Health authorities need to hear about it. Reagents have to be shared quickly, and we need to be careful about how we communicate risk and reality to the public. Public health interventions have to be based on science, and they should need to be overestimated or underestimated. We've overestimated the impact of travel restrictions, but we underestimated the impact of masking. So it's very important to let the science drive advice to the public. Innovation these days is something that is much more available around the world in places like India and the US, and we should use our innovation biotechnology to meet all of these new threats during times of threats and in between them. We know that we can develop drugs and vaccines in months, but we're better off preparing them in advance for things we think might be coming. And it's important as we implement either biomedical or public health interventions that the public trust those of us who develop information and our political colleagues who try to implement public policy. Because without trust, people won't take vaccines, they won't wear masks, and they won't take the right drugs. And finally, we need to expect the unexpected and be ready to pivot when things change. We have many tools to meet pandemics and epidemics. We can reverse them with what we know about public health interventions, isolation, quarantine. We know how to interdict transmission between people when we learn about how a particular pathogen is being transmitted. We can develop vaccines and treatment, and we need to use all of these tools to our benefit moving forward. Thanks very much for your attention. And as one of my favorite authors, Lee Child says, hope for the best, but plan for the worst. That should be our mantra as we look ahead to dealing with new pandemics. Thanks very much, and good luck with the rest of the conference.
We now move on to our next talk by Dr. Savita Baba on aging and frailty in HIV. Frailty is part of normal aging, and it has been seen that HIV population is living longer, but they're aging faster than non-HIV people. So there are a lot of theories to that, whether for instance, HIV is pro-inflammatory condition, there is toxicities due to the antiretroviral drugs. So there are a number of theories about frailty in HIV. So very much to talk about aging and frailty.
This is where I grew up and went to school and went to Lady Hardy Medical College here. This is my hometown. So thank you. So this is the outline of my talk. I'm going to have divided it into 5 sections: survival and lifespan, inflammation, frailty measures, interventions, and then some general comments. So here is an article showing the probability of deaths due to HIV/AIDS. In 1986, it was 51% deaths in 1 year and 85% in 5 years. And this slide shows the decline in virus load with different treatments as they evolved until the landmark event in Vancouver AIDS conference, when the concept of 3-drug cocktail was presented that changed the face of AIDS. The same concept presented differently is shown in this slide. In the early days of the HIV epidemic, the average age of people diagnosed was in the mid-20s. I'm talking about the US here. And the mean survival was less than 1 year. And in 2011, the same person would live for 50 years or more. And today, our delivery is simplified, 1 to 2 pills a day, and continues to evolve. The survival gap has shortened greatly, as you can see. And in HIV versus no HIV, and there may be no gap if treatment started early, below 500 counts. Now, the leading cause of death has changed from AIDS-related opportunistic infections to chronic diseases. So, in the issue of HIV and aging in the era of ART, one could say lifespan of people with HIV has improved dramatically. So, what is the problem? It's nearly normal. So here is the problem. As Dr. Divan just said, the health span of people with HIV is poor, with poor quality of life. And people with HIV are suffering from comorbidities at a younger age. And the question is, they're also experiencing multimorbidities. The question is why? And so here is a picture of two individuals at age 80 years of age. See how different they look from each other. I would like to be like Mr. Warren here at age 80. I'm sure you would too. And here I want to introduce the concept of chronologic aging and biologic aging. So imagine the life, the car of life. And these are the two cars here. It's really the same car, showing the pace of aging. The top is chronologic aging, and it is based on birth year and portrays how long you live in calendar years. And in the bottom is biologic aging, which is driven mainly by life stressors. And it's variable for different people and accounts for heterogeneity in old age. And there is a triangle, which is the gap between the two. Here it is almost zero for the top card and 10 years for the bottom card. And that is chronologic age is 50, but biologic age is 60 years. And at this rate, without any intervention, this is what we're going to expect to happen at age 80. And in HIV/AIDS, premature aging, it means that biologic age is greater than chronologic age. And people are still considered old at 50 years old if they have HIV. And this should really change. And critical knowledge gaps exist how HIV and its treatment really impact and interact with normal aging. So the keynote driver of biologic aging is inflammation, which was discussed extensively yesterday. And so one could say, what causes it, and can it be deleterious? And so I will discuss inflammation, immune senescence, and cellular cells. So in terms of what causes it, there are multiple factors which have contributed to it. The first on the top is mitochondrial translocation, resulting in macrophage activation and secretion of inflammatory mediators into circulation and tissues, and also influenced by the nature of the microbiome itself, which is more pathological than HIV, and the life stressors such as infections. Old age per se decreases immune function, and older people suffer more from infections like influenza, and COVID was a prime example. And then we heard a lot about obesity caused by drugs and lifestyle. And we must remember also poverty, mental illness, etc. And then HIV itself and heart toxicity, residual HIV replication, all contribute to chronic low-grade inflammatory phenotype called inflammation, which leads to deleterious consequences listed here on the right side, such as end organ disease, frailty, lymph node fibrosis, immune senescence, impaired immunity, and also seeding of the viral reservoirs as a result of inflammation. And old age itself in the field of geroscience is considered to be a major contributor to inflammation itself. So here are the diseases characteristically observed in old age. with an inflammatory pathogenesis, and you could include depression also. In people with HIV, the same conditions occur. What is not entirely clear is the different mechanistic pathways involved that lead to these different conditions. And so that is an important area of research. And shown here are two papers published along with Dr. Kumar Sani, with whom we collaborated together. We worked on this question of new correlates of cardiovascular disease risk in HIV infection in a Chennai cohort through an NIH-funded grant. And these were virally suppressed patients. And here we could also find the link with inflammation and identify the checkpoint molecule Day-3 to be associated with cardiac toxicity. My own research lab is focused on studies of immunity in aging and immune response to vaccines. Particularly, we study the influenza vaccine, and we have found several signatures of immunosenescence with defects in B, T cells, and monocytes in phenotype, function, and transcriptome. In the context of this discussion, I want to mention that this study is showing excessive immune activation in people with HIV at all ages, and also people even without HIV having inflammation. And so the figure A on top shows expression of immune activation markers DR and CD38 on CD4 T cells at higher frequencies in HIV positive individuals compared to HIV negative, regardless of age. And these ring graphs represent combinations of 5 immune activation markers, CD38, TR, PD1, ICOS, and KI67 on CD4 T cells in healthy controls and in people with HIV. And in young and middle-aged and in old people, it can be seen that in each ring, there is a relative frequency of cells expressing 0 to 5 activation markers, and which are greater in HIV for each of the age groups. So basically, the conclusion was that HIV is associated with far greater T-cell immune activation, and this is independent of chronologic age. So in the same study, we found excessive inflammation, both in young and old, as measured by a cytokine score. And these are the different cytokines. And at all ages, the cytokine score was greater in people with HIV as compared to people without HIV, and it increased with age. The important point again is that aging is associated with inflammation in both groups, but it is greater in people with HIV, even at a younger age. I just want to stress that. And here is a graphical abstract on the effect of aging and HIV infection on immunity. Our immune system deteriorates as we age and inflammation increases. And this immunologic aging is faster in people with HIV, such that young people with HIV are resembling old people without HIV, and the disparity between young HIV negative and young HIV positive is very vast in terms of their immune status. And so in addition to inflammation, I want to introduce this concept of this neuro understanding of cellular senescence promoted by the neuroscience field. And in this, what they say is that the senescent cells accumulate in tissues in aging and disease. And with various physiological conditions, they are in a state of proliferative arrest and use senescent cell anti-apoptotic pathways to maintain their proviral survival networks, which are shown here. And they also have this senescence-associated secretory phenotype called SAS, that can damage the surrounding tissue and cause inflammation. And so this is, we'll come back to this later in terms of therapies. So in terms of summary of this section of the talk, one can say that inflammation and dysfunctional innate and adaptive immunity are likely to be key players in biologic aging. Immunologic aberrations are evident even in young persons with HIV. A lot has been to be learned yet about various mechanistic inflammatory pathways for target organs and the timing of cellular senescence in relation to age in people with and without HIV needs to be explained. So let's go on to my assigned topic of frailty measures and associated conditions. We come back to our two friends, they're not really my friends, but so here's Mr. Warren and Mr. A at 80 years. And we could say that their phenotype is a reflecting an outcome of biologic aging. And of course, the person on the left is obviously frail, but there is also in between a vast spectrum of pre-frail and frail, which is not as extreme as the one on the right, on the left, sorry. And so frailty as such is related to a number of geriatric syndromes, which are listed here. They're all interconnected. Each syndrome contributes to the cause and consequences of others, and falls in particular are of particular concern because of the higher prevalence of low bone mineral density and fractures compared to the general population and who are not infected with HIV. But factors also involving cognition, including depression and neuroactive medications and cognitive dysfunction complaints are strongly associated with falls. And sarcopenia, which is listed on the top, is associated with a greater probability of mortality. But coming back to frailty, how do we test for frailty? Of course, you can look at a person and conduct a self-reported questionnaire, but this is really not so useful. Objective physical function assessments are the most reliable, and the two main frequent ones used are the Frail score and SPPV, which is also called the short physical performance battery. And then there are also laboratory measures such as the RAGS index. The Fried score, which was the first one that I mentioned, reflects a vulnerability as a result of multiple impairments. And it's based on evaluation of 5 physiological domains listed here, which are slowness, weakness, low activity, exhaustion, and weight loss, with categorization of individuals as robust, frail, or frail in ascending order. Studies in the era of ART have continued to demonstrate a higher prevalence of frailty among HIV-infected compared to uninfected persons, and though it is lower than in the pre-ART era. And this is how you do the SPPV. It has 3 components, each graded from 0 to 4 points. The first is balance or stance, and there are 3 positions next to each other, one behind the other, and then one really behind the other. And the second is gait velocity, and the third is sit to stand time. And the summary score from is from worst to best is 0 to 12. And this SPPV can be conducted in 10 minutes. This is a flow chart to show how you proceed from one test to the next, and the time required from 2 minutes to 4 minutes, as well as how you score each test. And there are a number of resources. Okay, so I can end. I think I just wanted to mention in the end that the interventions, among the interventions, the main ones are exercise, nutrition, behavioral modification, medical management, and biologics.
And here I wanted to at least leave you with the concept of new neuroscience guided trial in older people with HIV, using, these drugs which are dasatinib and luciferin, which are going to be now tested in older people. And the goal here is to use senolytics, which are agents which selectively eliminate this SASP secreting cells. And various new things are coming. You heard a lot about exercises yesterday, and it really does make a big difference. And finally, there are some key points in caring for older people, which already has been discussed at great length here. And other recommendations also exist. And so thank you. And I hope we can all be inspired to go, like Mr. Warren said, go after all the good food that we need to hear. We really need to do that. Thank you.
Thank you, Dr. Pava. Any questions if anybody has on Day-3? Thank you very much. I now invite Mr. Manoj at Day-3 to talk on challenges in accessing unlinked government.
I request Dr. Gira next time maybe we can have a mini session at the first day, second day, not at the last. Okay, so quickly, like one thing I learned good about my topic is uninterrupted ARV. Whenever we talk stock out, there is a huge pushback comes from the NACO that it's not stock out, it's a shortage. And then whether it is stock out, whether it is shortage, whether it's in transit or in go down or relocation, whatever it is, as a receiver or as a client, for me it's an interruption. And that interruption, being a public health approach, is not a good strategy. So largely 90 to 95% people are those who are on one, like the combination of TLD and all. Even one good step happened in the recent stock out, and also the credit goes to NACO. From 1 year procurement now they are procuring 2 years, and that might also help some level. If you see the history of 17 years, only 2 years there is no stock out. Rest every year, some or the other medicine is uninterrupted. As a program or as a community also, what are those barriers? Like if it is frequently coming, either it is a procurement related issues, then maybe jointly, like the program and community can constructively sit together and find out like what are those gaps and those issues which hindering the procurement process. And one thing which and Dr. Goa is also here, we are in THG, and we raised this issue. In last talk out, lots of OMs has been come one after another, like switch from this drug to that drug. Don't stop these drugs, use these drugs, all those stuff. One OM was little bit concerned. It was clearly mentioned that without viral load, just shift from one medicine to another medicine. So all these approaches as a public health approach is not good for the program. And lastly, like what the recommendation which to NACO and maybe for all the doctor brains here. Critically assess the gaps in the entire procurement process, constructively work on it and fix that gap. Because if all those things which we are seeing, aging related issues or adherence related issues, or it will add to each other. It has a multiple effect if interruption is there. And one major issue is coming up again is the quality of drugs. Since the global fund support is not now there in the it's all domestic purchase. Most during the stock out and currently also, like lots of drugs has been purchased from the companies which don't have any experience of like manufacturing. They are just the kind of contractor kind of people. They are manufacturing drugs, and we did a quality analysis, and that rate was that quality analysis is not actually good. It's only 47% absorption. So all these issues also are the outcome of like to do something in hurry and take address the issue of interruption. And maybe I'm a Davis advocate, but this we are telling our community also. Those who can afford, like at least they can they can buy 1 month medicine and keep it with them. As a like it's a people take insurance so that something will happen in future, it will taken care. So why not community, those who can afford, can buy 1 month medicine and keep it with them? Because largely I see the stock out maybe sometimes 1 month, 15 days, 20 days, and in that period they can use that medicine and continue the things. Lastly, like I know that 16, 17 lakh people is on the treatment. I know that average 85,000 new people will get started on the treatment. Yesterday, Dr. Puri was talking about expiry and all those. But is it like, as a layperson, and is it that much of issue that I cannot forecast that, okay, if this is my data showing, and I should do this much of projection and do the order. Those kind of stuff like the entire forecasting, giving orders in the time. What is happening that even if I know my stock that I have a stock of 6 months, the NACO is sending letter to SACS on the last month, you procure yourself. Whatever process NACO has to follow, the same process SACS also has to follow. And because both are government, you cannot say that, okay, SACS can do it magically. It's not possible. So the taking to SACS at last moment is actually then causing the issues. So even the coordination between both at right time, at right juncture, that is also needed. And I request SACS also to push back to this, that if they tell us in time, some measures at grassroots level can be done. And lastly, any interruption, if that my virus don't know whether who is failed, the medicine is not going, will that is becoming a trouble for my body. Thank you so much.
Thank you, Mr. Manoj. There's some very important issues that you raised. I'm glad you did that because that is actually a very frustrating problem in government sector. Now I'll invite Dr. Ruby Bansal to speak about immunization in HIV. Dr. Ruby.
Yeah, thank you. I think it's a difficult task at the end of the session. Yes, but I mean, the next speaker also getting
So I will just quickly finish this, and I have removed the many of the slides from my presentation already. So immunization, as we know, it's a very important, definitely very important. We have just listened about the aging. We have listened hepatitis B. We have listened about the influenza and pneumococcal infections, all which are happening, and PLHA are more they can have the more infections of these diseases because of the immunocompromised status. So we know around 23 lakh people living with HIV in India, and this is the second largest population. With the ART, with the wonderful ART, especially the dolutegravir and other drugs, so we have the longevity. So we are getting the even elderly population, and that's why the comorbidity is very high, and we have the more infections. So then value of the vaccination need to be addressed. That is very important. So we know this history about the vaccination, which the disease, the vaccine preventable disease has been even eliminated. Like the smallpox, diphtheria, measles, polio. Polio is about to eliminate, and rubella and tetanus. So we know the efficacy of the vaccines is very much high, and they are definitely working. So are vaccines, that is the question, are vaccines only for the children? Definitely, I think after the COVID, at least we should understand the vaccines are not limited to the children. And COVID just has shown the efficacy of the vaccination among people of all age groups, because we were not having anything else except the emergency use of the vaccine during this COVID pandemic. So that's why we have to fight with the COVID hesitancy, and this can be done only with the awareness among the general people. So there are compelling reasons for the adult vaccination. We know protection from some childhood vaccines can wear off with the time. We know about the diphtheria, tetanus, pertussis, and that's why the booster is important, which is the very well documented. Viruses and bacteria changes over time. We are seeing with the influenza, we are seeing with the COVID. The variant changes every year, so we need to vaccinate. Immune system tend to weaken over time, putting older adults at higher risk of the vaccine preventable disease. Influenza and pneumococcus, definitely the people who have taken the vaccine in the childhood, but with the age, and especially when the hepatitis B, you'll see with the comorbidity condition, the immune response decreases to 10. Adults who have certain chronic or immunocompromised conditions more likely to develop the complication from the certain vaccine preventable disease like shingles, pneumonia. Adults can infect other, definitely. That is also in the process. If the adult is getting infection, they can infect their younger children who are at home or the newborns also. So this is a few data, this is the old data about the United States. So vaccine preventable adult disease cause long-term illness, hospitalization, and even death. And financially also, economically, it is not good. It's a burden. And it's a data from the United States, but I'm sure India must have much more than that. So each year, an average of 220,000 people are hospitalized due to influenza. And among that, 3,000 to 49,000 die of influenza and its complication. This is basically around the 2012, or it's data from the 2011-12. So at that time, maybe the H1N1 like epidemic sort of the thing, and it is happening every year. There were approximately 32,000 cases of invasive pneumococcal disease in 2012, and there were around 4,000 deaths also. So 8 lakh to 1.4 million people suffer from the chronic hepatitis B, which is a very, very well vaccine preventable thing. We have heard about this in the previous lecture also, how we can prevent, and it is creating the burden for the cirrhosis of the liver and the transplant of the liver. So there is a lot of burden, economic as well as the with the illness. 1 million people get the shingles, and some will have the severe pain that can continue the long after with the rash clears up. We are witnessed with that shingle disease. And this is the time they keep on complaining. I have this the pain, the shoulders. We say it is a neurological pain they suffer. So there are many articles have emphasized that we need to improve the adult immunization rates in India. This is the article of 2014. So substantial improvement and increase in adult vaccination is well needed. We all know this, only thing we need to emphasize. Incomplete and inadequate immunization in India against these communicable disease results in the substantial and unnecessary cost, both in terms of the hospitalization and the treatment. So this is in way the burden is very high. Economic burden is very high, and as our infrastructure also, for the infrastructure also the burden is high. The government of India, as well as the World Health Organization, consider childhood vaccination as priority. We all know everyone has given the vaccine to the children, irrespective of the cost, irrespective of the place. So whether it is in the public domain or the private sector, so this is the well documented program, and but there is no yet focus on the adult immunization, neither in the public sector nor in the private sector. So and that is the most ignorant part. Just a brief about this is herpes zoster is a new vaccine which is about to come in India. In the next month it will be. It's already launched. It will be in the market. So in the HIV infection, you can see the 11.78 incidents per 1,000 persons per year. So in adult, in PLHA, it is more prevalent. As in for the every adult is important, and in the European countries and the America, this is a must vaccine for the adult population, so they are taking it. But the India, definitely not. So general principle for vaccination in PLHIV. We know killed or inactivated vaccine. There is no danger for the immunocompromised people, and they can be administered as recommended to the other. But only the live virus or live bacterial vaccine like BCG, polio, cholera, typhoid, and now typhoid we have the conjugated, so that is also not a problem. So we need to be cautious about giving them to the PLHA. So vaccine, when can we assess? We can assess the vaccine, about the vaccine, even at the point of the care when the patient is coming for the HIV diagnosis, at the first, and at enrollment into care, initiation of ART, stable, when they are stable with the ART, and at the treatment failure also. So any part of the time, we should do it every time. We should emphasize when the patient is coming to you. So this is again the HIV exposed infant, children, and adolescent, and they should receive the all vaccine as part of the routine vaccination with the national immunization schedule. So we don't have any doubt for the children living with HIV or with HIV positive mother, they should be enrolled as a part of the normal immunization program. So influenza, these are the common diseases which are more prevalent. Influenza, hepatitis B, pneumococcal, and tetanus, which is more prevalent in this population. And in HIV patients, why? Because they are more at a risk of getting these infections. Significantly increased risk of pneumococcal disease. There are more cirrhosis and hepatocellular cancer. Increased risk of morbidity and mortality due to influenza infection. Plus, as already they are immunocompromised, if they are getting any other infection, so definitely it is mortality is high. They have high risk due to regular contact and shared transmission routes. So whether it is the IV drug user, whether it is a sex worker or MSM, they are more into the more risk of the hepatitis B, hepatitis C, and the human papillomavirus. Hepatitis C, we are not talking because we don't have the vaccine for that. High risk of contracting HPV and HPV-related cancers, which are on rise. Varicella zoster virus, we already told this is at the high in the immunocompromised population. HIV-infected travelers, very important thing, when the travelers, they use pass. I will not get visa because मेरे पास ये vaccine नहीं है. I will not get that thing because how can I take this vaccine? This needs to be emphasized, and we should know when we will know ourselves what kind of the vaccine we can give or we cannot give. So otherwise, how we will just support the patient or can give the answer of his queries. So vaccine is pre-exposure prophylaxis, very important. Why we are giving to the children? Because as they should not expose, they should not get any kind of the infection. So, but why not to the adult and especially the key population? Why we are not using the vaccination as a pre-exposure prophylaxis? We are a lot of many of talk about the pre-exposure prophylaxis and post-exposure prophylaxis of HIV in terms of the pill. But we are not talking about the vaccination as the pre-exposure prophylaxis, especially in the MSM. Yes, all the vaccines should be given. The hepatitis A, B, HPV, meningococcal. I mean, there is need. We have the guidelines where we can give which vaccine. Influenza vaccine, hepatitis B vaccine, and anything. So, man having sex with the women, so commercial sex, all the women's, all the people who are in injected drug user. So, this is a key population, which is a high risk population, and we have a high burden of HIV. So, they should be, I mean, like given these vaccine, access to these vaccine as a pre-exposure prophylaxis. So before they acquire this disease. So this is HIV infection with CD4 count is 200 and greater. What all vaccine we can give? Yes, now the new guidelines is COVID for all. And most of them have taken. And we have seen there was no much side effect or something. And definitely there was a prevention from the COVID serious illnesses and the mortality. Influenza vaccine each year to protect the sick. Now we have the quadrivalent vaccine, and which is covering the more variant of this influenza. And you have seen this was the for the last 2-3 months the influenza cases were on rise in the whole country. And this cough and cold, which is not going, they are not serious, but which is not going for the long. I mean, 2 months, people are coughing without fever or anything. So, somewhere we can prevent. Tdap vaccine to protect against tetanus, diphtheria, and whooping cough, and we have somewhere eliminated this disease. Pneumococcal vaccine to protect against pneumonia. Meningococcal, whenever there is a need in the endemic situation, hepatitis B vaccine should be for all, and the HPV vaccine for all female, and now it is already approved for the male in India. So up to the 26 years of the age, especially the man having sex with the man, or even the young adults, because we all know HPV virus stores in the man, and they are the carriers, and they are giving it to the women, and it can cause the infection in especially in the MSM population as a anal cancer or the any other oral cancer, HPV related oral cancer. MMR vaccine. I mean, we were talking about this. Monkeypox and this thing. So there was again the smallpox vaccine was there was a thinking who has taken the smallpox vaccine, they can be prevented from the monkeypox. So vaccine and the new emerging infections are also looking for the what kind of the vaccine has been given in the past. Zoster shingles vaccine, 2-dose series of the shingles, which is about to come, and it is already in India, but it will be available soon for the population. HIV infected with the CD4 count less than 200, definitely COVID for all, influenza for all, Tdap, pneumococcal, meningococcal, hepatitis B, and HPV. Because all the kid vaccine can be given. Only thing should be cautious about the live vaccine for the population. And definitely we know the immune response is good when the CD4 is high. So just look for, you need to choose the patient accordingly when to give which vaccine. So these are the ACIP guidelines for adult with HIV. This is well available, and now CDC has a very good app, mobile app. You can just have that app, and you will know about all the adult immunization or the childhood immunization, whatever any queries. You just check with that, and it is easily accessible. So very handy app. This is a very handy app. So these are the National AIDS Control Organization guidelines, which is for the children, which is well established, but there are no guidelines for the adults as such. This is British Columbia Center of the Disease Control, which are all recommended. Like all organizations are giving the guidelines for the adult immunization. So it's a high time we need to think for, and we need to introduce we need to make our guidelines, and we should implement all these guidelines. So that's all with my talk, and I thank you very much for this opportunity. And with the only message is just think about the vaccine. Start asking the patient whether they have taken or they should take. Right? Thank you.
Thank you. That was a very, very enlightening talk. And I hope it's loud and clear. For next talk, which is last in the session today, I'm going to invite my dear friend, Dr. Girish Nadu, who is carrying forward Delhi Medical Council on his shoulders. All these years, he has been at the helm of affairs. He is the secretary, he is the registrar, all of this gets members done with him. And he is going to talk about code of medical ethics, an important issue because when doctors are challenged, when there are complaints, they all go to him and their team. And so I invite Dr. Girish Nadu.
Thank you, Dr. Richa, for the kind words. Thank you, Dr. Ishwar, Dr. Budi, and other organizations for giving me the chance to talk on the health issues. And of course, it is a conference which is being organized for the national conference for the AIDS. Doctors who are still practicing in it, and of course, not only that we are practicing only the AIDS, we are practicing the other medicine because first of all we are doctors. At Delhi Medical Council, I'm the registrar cum secretary and received number of complaints against the doctor for the professional misconduct and negligence, and nearly 35 to 40 complaints per month we are receiving. That means 1 to 2 complaints per day we are receiving against the doctor for misconduct and negligence. And there are ethical and legal issues involved with that complaint. If the doctor is practicing in Delhi and registered with Delhi Medical Council, whether the complaint is being filed at the PMO or the president level, or at the High Court or the National Human Rights Commission, ultimately the complaint will come to the Medical Council for adjudication. And we have a system in deciding the complaint. Once the complaint is received, it is put before our executive committee. Executive committee prima facie looks into it, and if they don't find any substance, they dismiss the complaint there itself. If they find there is some substance, then we ask the clarification from the doctors or the hospital for their defense. And then it is again put before the executive committee with experts, and it can be dismissed at that level, or if experts feel that there are certain issues which needs to be clarified or deliberation, and of course it is put before the disciplinary committee, which is provided in that it is a 6-member committee. Out of these 6 members, there are 3 members, non-medical members, and 3 are the medical members. 3 non-medical members in the committee are the 1 MLA is there, 1 legal member is there, 1 emeritus man is there. And the 3 medical persons are 1 chairman of district committee who is a doctor, then 1 member of representative of the Medical Association, and 1 11th expert of doctor. So, as I told you that about 35 to 40 complaints per month we are receiving. And then how this litigation is going to increase, because when I joined in 2007, practically we are receiving around 15 complaints per month or so, then now it is 35 to 40, and it is going to increase. The impact of increasing complaint is primarily because of the Consumer Protection Act, which came in 1986, then came in 1995, VP Shanta case, in which the medical profession brought into the ambit of CPA, then comes in 2013, famous Anuradha Saha case, in which the doctors are being given the penalty of compensation of 5.96 crores, and with interest it came out to be 11 crores. That means in the future, there is no hope for the doctor that the litigation will be going to be increased because of this. And just look at what are the options available for a patient or the relatives to file complaints, or they can go to the consumer court for compensation for deficiency service. They can go to the civil court for also for the compensation. They can go to the criminal court, that means to police, for when they think that doctor has done something negligent for which he should be jailed. They can go to the police or to the criminal court. They can go to the High Court under Article 226 or under to the Supreme Court under Article 32 for violation of fundamental rights. And we are receiving complaints also from the National Human Rights Commission. That means they are nowadays the patient with the relatives are directly going to the National Human Rights Commission for their complaint against the doctor. Then they can go to the State Medical Council or District Medical Commission for disciplinary action. They can go to that if there is a violation of any state act or the Central Act like PC 2080 Act or Biomedical Waste Act, Nursing Home Registration Act, Medical Termination Pregnancy Act, etc., they can go to for various authorities. That means these are the options. That means 7 to 8 options are available for the patient or the relatives, and unfortunately, they avail all the opportunities simultaneously. They apply to the consumer flow also, they apply to the police also, they apply to that state medical council also, and state government or central government also. And of course, doctor has to reply to various authorities simultaneously one by one. Every 15 days, doctor is getting a notice from the state medical council, then police, then consumer court, then criminal court, etc. And we have sent representation to health government also, health ministry also, that at least the patient or the relative decide what they want. If they want a compensation, they can go to the consumer court. If they want a criminal action, they can go to the police. If they want a disciplinary action, they can go to the state medical council or national medical commission. But of course, because of political reasons, nobody want to take it. Just to be the general public, they cannot issue such as the directions. And of course, situations like that, they are applying to different authorities simultaneously. So when can you think of that the patient is going to be filed complaint against you? That here also in my own knowledge, based on experience, it is A, B, C, D, E, F. A stands for adverse outcome under event. Whenever there is likelihood and adverse outcome under event, be prepared that patient is going to be filed complaint against you. B is the behavior of doctor, nurse, nursing orderly, sweeper, physiotherapist, technician, etc. Whosoever involved in the treatment, if the behavior is not satisfactory, they will file a complaint if there is a not getting a desired result. C is the communication, and C is the comments of other colleagues. First of all, the comments of other colleagues. From our experience, at least 35 to 40 complaints, 40% of the complaints, there is a doctor behind that. We have seen that because just going through the complaint, we came to know that there is the literature provided to the complaint, the language by the complainant. It is absolutely clear that there is a doctor behind the complaint. That is very unfortunate part. 35 to 40% of the complaint, there is a doctor behind that. And C is a communication. Communication, of course. We are very poorly in communicating with our patients because in our times, communication was not in our curriculum, but meeting with the Medical Council of India simultaneously and the various meetings that have been missed. Now it has been part of the curriculum because once upon a time that doctor was treated as a god, but now the thing is absolutely opposite of that. And if you are not communicating with that patient or the relative, and if they are not getting that desired result, they will file a complaint against the doctor. D stands for desired doctor-patient relationship, which of course, once upon a time it was supposed to be a biased relationship, but now that based on the faith and trust, now there is no faith, no trust, no confidence on the doctor. They think themselves the consumer, and they think that doctor, we are paying for the doctor or the hospital, and they are really for the doctor. And D stands for also the decision-making involvement. If you are not involving the patient or the relative in the decision-making, and if they are not getting the desired result, be prepared that they will file a complaint. So gone are the days when you think that without taking confidence of the patient, you are going to treat. Nowadays, they are the aware patient, they are coming to you after going through the Google or asking their discussion with that some friends and relatives who might be doctor, and you have to involve themselves in the decision also. E stands for expectation of the patient or the relatives. That is suppose a patient of stroke admitted under a neurologist under a hospital, if he is admitted at the right time, they think that once they are admitted in the hospital, they should get a proper response. From the doctor point of view, he might think that patient is progressing freely, but not from the patient relative point. They think that once 1 week is over, the patient should behave normally, he should walk, he should run, which is of course not possible for that matter. And F stands for financial, that means it generally applies to the private sector because the patient is going to the hospital with a certain budget, and if there some complication occur because of it, patient is being in the ICU or ventilator or some added operation is being done. Because of that, there might be the balance in the budget, and if they're not getting the result, they're filing it. So A, B, C, D, E, F. A stands for adverse outcome or B stands for behavior, C stands for communication and comments orderly, D stands for that doctor-patient relationship and decision-making environment, E stands for expectation, and F stands for financial. Then how can we reduce that reduce? Here also that ABCDE stands for availability of manpower, method, machine, and material. These all things should be available. We have every fortnight or so we are discussing in the news or in the media that doctors are being assaulted. There is a violence at the hospital or the nursing home, also in the casualty or in the ICU or in that region. We have to maintain that ABCD, availability of manpower, method, machine, and material. That means the doctor, nurse, nursing orderly, trolley, machines, etc. should be there in the right time. B stands for behavior, which I already told you that the behavior of doctor, nurse, nursing orderly, sweeper, technician, physiotherapist, dietitian, whoever is involved in the treatment, behavior should be satisfactory, and we have to tell our engineers to behave for that matter. C stands for communication, which is very, very important, which I already told you. Here also there are two aspects. Communication, communicate effectively to prevent error. That is with our team members and for the doctors. Because we have seen that now the patient is being admitted under a multidisciplinary team where the medicine people, neurologists, or other specialty persons are seeing the patient. They are coming at different times. They are not communicating with each other. But sometimes they are documenting, sometimes they are not documenting, and because of that, the nurse will giving the treatment either the patient is getting a lower dose, higher dose, sometimes dose is missed because the verbal instruction is being given to that. So if you are effectively communicating with our team members, chances of are that the error will be less. Once the error less, litigation will be less. And communicate effectively to prevent dissatisfaction. This is for the patient and the relative. If you are effectively communicating with the patient and the relative, likelihood that they will be less dissatisfied. When they are less dissatisfied, the chances are that they don't file a complaint. And it should be two-way communication. Ask the patient and relatives to have their queries and try to address them. Gone are the days when because sometimes it is think that when the patient or the relative asking a question, they are challenging the authority of the doctor. We think that they are just challenging our authority. So it should be two-way communication. Ask them to have a so communication is very, very important. We have seen that sometimes the patient dies, and after death, the relatives are touching the toes of the doctor. That's you have done everything. Our fate was like that. What was not with us? And in another scenario, a slightest complication which is mentioned in the books happens, and they are filing and going for the abuse, going for the assault against the doctor. So it is the art of the communication which is for that matter. And D stands for documentation. Documentation is very, very important from the point of view that the case, whether it is a state medical commission, council, or national medical commission, or consumer court, or criminal court, or high court, will be decided based on the documentation. And we are very poor in documenting. From our experience, we have seen that when the case comes to the committee, the surgeon who has put up the notes in the files is not able to read his own notes. It is fact. We are asking surgeon to read his notes because we are not able to read his notes. And surgeon in front of the disciplinary committee, with the MLA member, legal member is there, eminent public member is not able to read his own notes. The hospital is not able to identify who has put up those notes in the files. The whole team is there, but the hospital is not able to identify who has put up the notes. And documentation, because ultimately the case is decided based on the documentation. If it is there are various judgments from the courts that sloppy documentation is equated with the sloppy care. If it is not documented in the file, it is presumed that it has not been done, whether you have done or not done. If it is not documented, it is presumed that you have not been done. And document everything, whatever the happening, whatever the treatment, complication, etc., should be documented in the files. In one of the cases, where the patient was operated with some was sent for the histopathology report, but it was not documented in the discharge summary. Once it was not in the discharge summary, then they didn't get that histopathology report, complication occurred, and then they went to another hospital. The action was taken against the doctor because it was not mentioned in the discharge summary that you have to get such and such report from the hospital from the report. So two things are of course very important from the documentation point of view. One is discharge summary and the prescription, because discharge summary is the patient and prescription is also the question. And communication and E stands for empathy. If you are empathetic towards the patient, then of course likely to. So just a carry on message that to reduce the litigation, one is communication, another is documentation, communication of documentation, documentation of procedure. If we follow just 20% of these things, litigation and the conviction against the doctors will be drastically reduced. I know that I have exceeded my time. Thank you, Dr. Richard and Dr. Lee and other organizations and Dr. Ishwar for doing that. Thank you all.
Even when they try to help the doctor, because he has not documented, so the case goes against the doctor. So if A, B, C, D, that D, or is there any E also?
Yeah, empathy.
Empathy, that is so important. That's thank you very much. I'm sure everybody has gone.
Just one word about the consent itself. Because we doctor take that consent is just a piece of paper. Consent is a very important document. And here we have seen that the doctors are operating on the patient without proper consent. If the consent is not proper, consent is not proper and valid, you are likely to challenge that criminal action. Because without proper consent, you cannot touch the patient. There is a Supreme Court case there, that's a Mirapolli case, which there is a elaborate explanation of the consent. With the consent, you are proper, you are likely to be face the criminal charges. You cannot touch the patient. We are operating the patient on the flimsy ground. Sometimes consent is taken by the man, sometimes consent taken by the patient. If the patient is major and of sound mind, consent has to be taken from the patient himself, not from the relative. Thank you.
And this very interesting session, this is the last session of this very wonderful conference. We have gone through emerging infectious diseases by Dr. Robert Schooley, and then we talked about, we have had Dr. Sanjay Pujari. These two talks were recorded or online, and the rest of the important discussion we had was on aging, frailty, immunization, and of course, what Mr. Manoj brought out was the problems in or challenges in accessing uninterrupted ARVs. I hope NACO is taking cognizance of that. And then we came the doctor will be talking about immunization, and in the end, Dr. Girish Jaggi. Thank you all the speakers. Thank you very much.
Dr. Richa Diwan and Dr. Giladar to felicit the faculty. Come on the stage. Dr. Girish Tyagi from Delhi, Dr. Dr. Savita Pahwa from USA, Dr. Ruby Bansal from Ghaziabad. Sir, felicit the madam.
Then
and be with us to watch this journey. It's been our journey as well. So thank you very much, people, for sharing this journey with us. Thank you and God bless.
So we are almost at the end of this ASICON 2023. On behalf of our Governing Council and Legal Society of India, I thank at this time. We also like to, thank all the, our funders and donors for this conference for your generous support with a token of memento here. Ishwar, let me give that. At this time, we like to invite the MQ representative here. MQ Satya.
Thank you very much. I'm more than what love and affection has shown all these years. Journey with ASICON started with foundation 2000. 2004 I have taken over as Secretary General, and 2011 December I have taken over as President. A lot of people would question why the same President for many years. Because they never allowed. Actually, for several years he is due, but he didn't want to. And it was very difficult task to convince him to take over. Now, whenever we are organizing conference, it is most important thing. How do we get support? And the support, Girish Tyagi was just come here. Medical council, lot of restrictions, income tax, public charity trust. But despite that, we are able to start the conferences from 2005. When I took over the mantle of Secretary General, it was minus 46,000 of budget of ASI. We owed money to lawyer and chartered accountant. And today we have 1.15 crore in our kitty. And that is thanks to our support. Since 2005, sometimes to the displeasure of our own colleagues, no alcohol, no smoking conference. At that time, nobody heard of such kind of conferences in medical profession. And we used to ask how many people are there. 10,000 delegates. In the hall, we will find hardly 100 to 105. But in our conferences, almost 80% people are always in the hall. And that is because of no alcohol conference, no freebie conference, no entertainment of the family or tourism conference. So if they want to be entertained, come before or go after. But we will entertain you in a hotel in such a way that you don't need to go anywhere. And since beginning, my principle has been for a conference, I check in and I check out. I never go out of the even hotel premises. I would like to see that everybody there. And second principle we adopted was everybody, whether it's a student or a scholarship recipient or a doctor or a delegate or a speaker, international, they will all stay in the same conference. Other principle we have adopted was the pharma company will support us. They used to stay somewhere else. And we realized that we got the conference with their support. Why not they stay also with us? So depending on the support, everybody gets to be here. So almost everybody stays here. And at many of the times we cannot make out who is who. With a pharma person or a delegate or a student or a speaker. And they interact and there are students are like many places in the world. That line I would like to first call upon and Pure Pharmaceutical. They have been our great support right from the beginning, and they have been support this. We can just expect them. Okay, Satya. Where is Satya? Okay. So Satya, Mangesh, and Sunil, please take the. About laboratory,